Assalamu alaikum. I'm Dr. Gulnaz Ayaz, working as a senior registrar, OBG department, Hussain Lakhani Hospital. I'm honored to welcome you all in this workshop being conducted by our department in Hussain Lakhani Hospital in collaboration with Pakistan Urogyne Association and Sindh Institute of Reproductive Medicine. Through this workshop, we will strive to enhance your knowledge and skills about repair of 3rd and 4th degree perineal tear. We will start our session with the name of Allah Almighty. So we'd like to invite Dr. Iram Tanzeem for Tilawat-e Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غیر المغضوب علیہم ولا الضالین آمین. میں پناہ مانگتی ہوں اللہ کی شیطان مردود سے. شروع کرتی ہوں اللہ کے نام سے جو بڑا مہربان اور نہایت رحم کرنے والا ہے. سب تعریفیں اللہ کے لیے جو تمام جہانوں کا پالنے والا ہے, بڑا مہربان اور نہایت رحم کرنے والا ہے, بدلے کے دن کا مالک ہے. ہم تیری ہی عبادت کرتے ہیں اور تجھی سے پناہ مانگتے ہیں. ہمیں سیدھے راستے کی طرف رہنمائی فرما اور ان لوگوں کے راستے پر جن پر آپ نے انعام فرمایا, نہ کہ ان کے جن کے راستے پر غضب کیا گیا اور جنہیں گمراہ کیا گیا. صدق اللہ العظیم.
Subhanallah. Now I would like to invite Professor Dr. Haleema Hashmi, our chief guest and Vice President of Pakistan Urogyne Association. Please, madam, come on stage. Thank you. Now, I would like to invite our Dean Faculty, Professor Dr. Masroor. Please come on stage, sir. I will call to invite Professor Dr. Shamim, Head of a Department Surgery in Hussain Lakhani Hospital. Sir, please come on stage. Now, I would like to invite Professor Dr. Muhammad Hanif, Head of a Department Pediatrics. Please come on stage, sir. I would like to invite Professor Dr. Shagufta Tahir, Head of a Department OBGY in Hussain Lakhani Hospital, General Secretariat, PUGA, Pakistan Urogyne Association. She has worked as an associate professor in Liaquat National Hospital and also as a head of a department in Sahiwal Medical College. I would like to invite Madam on stage for a welcome address.
Assalamu alaikum, all of my guests, chief guests, guest of honors, dear participants, and the participants who are on the Zoom, on the behalf of the Department of Obs and Gynae, Hussain Lakhani Hospital, Iqra University. I am Professor Dr. Shagufta Tahir. Most of you know me, but if somebody have no idea, I am working here as a professor and head of department. This workshop is specifically organized for the postgraduates and the consultants. In fact, we being the part of the OBGYN people, we have to tackle the obstetric cases, and the normal delivery is not always a normal one. It get complicated most of the time, and if you perform the episiotomies and you deliver the baby, sometimes that baby doesn't come very easily. And it end up onto having the perineal tears, the episiotomy which get extended, and it may break the anal sphincter. And that is an emergency. which need to be tackled at the same time. And if you miss at that time, so the patient is going to suffer for all her life, because the fecal matter would not be content. They would be incontinent for the fecal matter. So this is a grave disease. We'll say rather it's a hidden problem. Most of the women who deliver at home, they do have these perineal tears. But unfortunately, due to the lack of the knowledge, awareness, and the expertise in a gynecologist, and they feel ashamed when they go to the surgeons. They do not go. Nowadays, we are lucky we are having the female surgeons, a lot of the female surgeons. And we have in our department, a hospital as well, in the department of Hussain surgery, these are the female surgeons. And who are really trained in breast and the colorectal problems. They are working in it. But most of the time, these patients, they come in contact with the gynecologist. They are the first people who are going to handle them. So they must be knowing how to repair that 4th degree perineal tear, and if the sphincter is torn, so how you are going to repair it. So this is a very specialized, highly skilled workshop, and I would suggest that the people who are on Zoom, they can see the videos, and maybe they would not be able to do the hands-on, but we have the part of the workshop, it is the hands-on, and then few of them the presentations, and where the videos would be played. There are 3 videos. And I hope in the end of the workshop you would be able to recognize, evaluate and perform. And if it's difficult, you can take the help of your seniors so that you can start doing it. You know, when you start doing it, you will attain the expertise in it. So welcome all of you who are the people on site and the people who are at the Zoom. And I know this workshop because it's going live, so it's seen in all cities of Pakistan. We have a lot of the participants from the other cities as well. So thank you very much for joining us, and I welcome all of you, and I hope you will get the good result, you will get the good learning outcome of it. Few of the household announcement. Please keep your mobile silent. In the end of the workshop, please make the feedback form, give it to us. And for those who are onto the Zoom, they would be given the certificate of the participation, but after they send us the feedback form on the link what we provide them. Thank you very much.
Thank you, madam. We are pleasure to have a Professor Dr. Muhammad Masroor, Dean Faculty Health Sciences, Iqra University. He is also a counselor, treasurer, College of Physician and Surgeon, Commissioner, Sindh Healthcare Commission. Sir is also a member governing body KMDC. Now I would like to invite Sir on his stage to share his views.
Bismillahirrahmanirrahim. Thank you for introduction. I have great privilege to welcome esteemed chief guest, Professor Dr. Haleema Hashmi, who is an asset of the medical fraternity. She is a great teacher and teacher of the teachers, I will say. She is also welcomed and with another aspect, and that she is vice president of the Society of Urogynecology, Pakistan. Also welcome the brilliant participants sitting in the hall, and those who have joined online also as for this very great workshop. I would like to congratulate Department of Gynae and Professor and head of the department, Professor Dr. Shagufta Tahir, for organizing this very, very important workshop, which is basically skill-based, not only the knowledge-based. The purpose of any workshop is obviously not to train to become an expert, but they play a very important role in standardizing and giving a standard and create an awareness about the perfection in the field, in the skills development. Today we are sitting here, but I can assure you and tell you that when you will reach this position where we are standing, there will be paradigm shift in the medical education. And most of the curricula now are, stressing upon competency-based and skill-based curriculum rather than just, imparting the knowledge. And many of us, those who will not be trained enough to have got skills to perform the procedure, probably they will be sidelined. So this is our responsibility as a teacher, as an administrator, to provide as much, opportunity for training as is possible. So this is the second, workshop over here, and I hope that other departments will also be conducting same type of the workshop, because we have got so many very learned persons, Professor Shamim Qureshi Sahab, Professor Hanif Ayman, and so many more. Taking the advantage of your presence and those who are involved in the gynae practices, I would like to highlight one very important point, and that is the obstetric outcomes. And very often speak about the maternal mortality and child mortality, both are interlinked. When I was in third year, I was taught that pregnancy is a physiological condition, and we never used to say a pregnant lady a patient. हम उसे मरीज नहीं कहते थे बिकॉज ऑफ दिस टीचिंग. मैडम रजिया अंसारी याद है डांटती थी कि भाई ये पेशेंट थोड़ी है. तो प्रेगनेंसी वाज और इज़ अ फिजियोलॉजिकल कंडीशन, बट व्हेन यू लुक एट द आउटकम it does not fit in that definition. Most of the time we land up with many complications, like what you are doing today. To learn is an outcome of a bad obstetric management. When I asked and requested Professor Shagufta Tahir कि भाई यहाँ पे obstetric practice को जो है हम करें, start करें, तो she very rightly stopped us. उन्होंने कहा कि नहीं, हमें ये भी चाहिए. We need a good labor room with all monitoring facilities. We need a baby warmer. We need a baby resuscitator. We need the help of the pediatric department. Then I approached the head of the department of pediatrics, and he said, no, we cannot start obstetric practice unless you give us and give me an NICU and give a ventilator. So then I realized how important this is, the post-obstetric care rather than just the pre-operative antenatal care. And because of the lacking of these things, many things are happening. What really I started talking about this is the mushroom growth of the maternity homes. जब मुझे ये बात कही दोनों प्रोफेसर साहिबान ने कि आप हमें ये भी दें, ये भी दें, I visualized so many maternity homes जहाँ पर एक ट्रेंड भी नहीं, अनट्रेंड लेडी डॉक्टर या कोई नर्स जो है वो मैटरनिटी होम को चला रही है. देयर इज़ नो फैसिलिटी फॉर केयरिंग द न्यू बॉर्न, उसके लिए कोई प्रिपरेशन नहीं है. मदर को क्या होगा उसके लिए कोई प्रिपरेशन नहीं है. तो हु विल लुक आफ्टर दैट? बीइंग एसोसिएटेड विद सिंध हेल्थ केयर कमीशन, I would like to inform you, and this is also with the Punjab Healthcare Commission, being a monitoring body for the quality of the healthcare, that we are receiving, related to the gynae I am talking about, two main complaints. One is the medical negligence, and second aspect is mostly that doing something without the scope of a person, without the privilege of that person. Simply to say कि सीजर कर दिया लेकिन वो she was not competent enough, the gynecologist was not competent to do. देखिए कॉम्पिटेंसी एक अलग चीज़ है और एक्सपीरियंस आपकी एक अलग चीज़ है, या अथराइजेशन इज समथिंग अदर दैन द कॉम्पिटेंसी. आपने 2 साल काम किया है, यू कैन डू सीजर, लेकिन यू आर नॉट ए पोस्ट ग्रेजुएट, यू कैन नॉट डू सीजर. तो आपको आता है करना, यू कैन एक्ट एज ए लाइक असिस्टेंट टू योर कंसल्टेंट, यू कैन नॉट डू, यू कैन नॉट परफॉर्म. तो आप देखेंगे अंबार लगा हुआ है इन कंप्लेंट्स का. एंड व्हाट इज मेडिकल नेग्लिजेंस? वेरी सिंपल डेफिनेशन by the Healthcare Commission, that is the legal definition, ke doing something which was not required or not doing at one time which was required. बहुत simple definition है. अभी पेशेंट को ज़रूरत थी कि नहीं भाई इसको तो लेबर पेन्स है या जो भी आप ज़्यादा समझते हैं, सीजर की ज़रूरत नहीं थी, आपने उसका सीजर कर दिया, उसकी कॉम्प्लिकेशन हो गई. या पेशेंट को जो है वो आप मैनेज करने के लिए आपके पास फैसिलिटी नहीं थी, आपने किया, आपने रेफ़र नहीं किया और आपने कर लिया. तो दीज आर मेडिकल नेग्लिजेंस. और ये जो चीज़ें होती हैं, आई बिलीव दैट दे आर इक्वली हार्मफुल एज दी जिसको आप क्वेकरी कहते हैं. वाई? अ पर्सन हु इज़ गोइंग टू अ क्वेक, उसको पता है कि भाई ये तो क्वालिफाइड पर्सन नहीं, गड़बड़ करेगा, आई विल बी केयरफुल. बट व्हेन ही इज़ कमिंग टू मी, he comes to me with the belief that I am a doctor, I know everything, and I will take care of the mother and the child. And then something happens. And the second thing is then doing beyond the scope. Privilege है मेरा, मेरे पास ये qualification है, ये experience, I can do that, beyond that I cannot do that. So these were just bitter facts which I like to highlight, because these associations, they can do a lot. I have stressed on the Healthcare Commission to implement a model for minimum requirement of an standard maternity home. वो एक डॉक्टर बना रहा हो या हॉस्पिटल के अंदर हो, उसको इंस्पेक्ट करें, उसको ऑथराइज करें, अदरवाइज उसको बंद कर दें, एंड ट्रीट देम एज ए क्वेक्स. तो हो सकता है कि आपको स्टेटमेंट बहुत जो है वो हार्श लगे, वो लगे, बट व्हेन यू टॉक अबाउट द मैटरनल मोर्टेलिटी, द मॉर्बिडिटी इज़ मोर इम्पॉर्टेंट, जो अभी मैडम ने भी पॉइंट किया था. ये उसको रोकने के लिए आप सबका ताउन, आप सबकी प्रमोशन बहुत ज़रूरी है. इन चीज़ों को आप हाईलाइट करते हैं और करते रहेंगे फोर्स के साथ, तो आई थिंक दैट विल बी डन. सो विद दिस फ्यू वर्ड्स एंड अगेन thanking especially Professor Dr. Haleema Hashmi. I wish Professor Shaheen Zafar was also here. Due to some very important reason she is not here. She is also a very senior person, and I appreciate her effort on one aspect, that she has made treatment of fertility a scientific and professional aspect rather than just going in the hands of someone who is not known. Thank you very much.
Thank you, sir. Director of Sindh Institute of Reproductive Medicine, Professor Dr. Shaheen Zafar, also supposed to come and attend this workshop, but unfortunately, due to her health issues, she will unable to attend this workshop. Secondly, Sir Naveed, Chairman of our Hussain Lakhani Hospital, Iqra University, Sir Naveed Hussain Lakhani, also supposed to attend this workshop, but unfortunately, due to his health issues, he is also not come. We are honored to have a Professor Dr. Shamim Qureshi, Head of a Department, General Surgery in Hussain Lakhani Hospital. He is a renowned general surgeon, and he has worked as a head of a department in JPMC. I would like to invite Dr. Shamim on stage to share his views.
Thank you very much. I must commend Iqra University and Hussain Lakhani Hospital and Dr. Shagufta and her team to organize this very important workshop. As a general surgeon and a colorectal surgeon, I've been come across a lot of problem of cloacal injuries following birth, and these injuries are seen by me after 4 years of surgery, pregnancy, delivery, sometimes 10 years following delivery. People are shy to come and see the doctor. We've been treating as elective cases in colorectal surgery, the whole colorectal injuries repair, and I have done about 15-20 late colorectal injuries repair. And I come to know these terms in 1996 when I was in St. Mark's, and the case of colorectal injury came, and the first time I was aware, what is colorectal injury? He said vagina and rectum is one. So when he said vagina and rectum is one, I was very worried that what had happened to that. And this is mostly time of fall or gynae and this. And then I saw 2 cases, 1 case there, and then when I was doing workshop here in Pakistan, the expert did 1 case here, and madam was talking to me, the senior who was one of the moderators in that course in JPMC was practicing that in Lakhani National Hospital, and how the technique is spread from 2008 onward, and in 2021 we are repeating the same thing on the animals to get an awareness of the cloacal injuries to prevent at the initial stage rather than coming to the general surgeons at the late stage, because the sphincter is lost. Sphincter losses memory of contractions. The patient psychology is quite different because they are incontinent for years and years and years. You need to have a complete reconstruction of the perineum, plus divergent colostomies, and this go on and on and on, and the 6 months and 8 months required. There's a lot of failure also in the operation. So it is a very important topic that you should do at the time when it is happening. And I must congratulate whole team members and the Iqra University as well as the Hussain Lakhani Hospital for taking such an important initiative by Madam Shagufta. Thank you very much. And I think it is a very good workshop. You should all enjoy it. Thank you very much.
Thank you, sir. Now we honor to have Professor Dr. Muhammad Hanif Maiman, Head of Department Pediatrics in Hussain Lakhani Hospital, Iqra University. He has worked in many renowned hospitals like Bakai University Hospital. He also worked as Associate Professor in Hamdard Medical College and a Head of a Department Liaquat Medical and Dental College. Now I would like to invite Professor Dr. Muhammad Hanif come on the stage and share his views.
अस्सलामु अलैकुम। गायनी और पीड्स या गायनी एंड नियोनेटोलॉजी गोज हैंड्स इन हैंड्स। बहुत सारे प्रॉब्लम्स जो हमारे पास नियोनेटल केयर में आते हैं एक्चुअली वो शुरू एंटीनेटली हो जाते हैं, तो बड़ा क्लोज रिलेशन है। और फिर मैटरनल मोर्टेलिटी और अर्ली नियोनेटल डेथ्स, अनफॉर्चुनेटली पाकिस्तान में जो सार्क कंट्रीज़ हैं उनमें हम हाईएस्ट नंबर पर हैं। हमारी मैटरनेटल मोर्टेलिटी भी बहुत ज़्यादा है और नियोनेटल डेथ्स भी वर्ल्ड में हम टॉप पर हैं इस वक्त। और बहुत सारी इसकी वजूहत हैं। इनमें से एक वजह यह है कि हमारे यहाँ जो डिलीवरीज़ हैं 50% हॉस्पिटल डिलीवरीज़ हैं, इसमें वो गली के छोटे छोटे मैटरनिटी होम भी शामिल हैं, और बाकी जो हैं वो होम डिलीवरीज़ हैं कि कोई भी सीनियर पर्सन या अनट्रेंड बर्थ अटेंडेंट वो डिलीवरी कराती है। तो जब वो बेबी को डिलीवर कराते हैं तो उसको साइड में रख के सारे लोग माँ को अटेंड कर रहे होते हैं जो होम डिलीवरीज हमारी हैं, और बेबी अनअटेंडेड रहता है जब तक कि माँ स्टेबलाइज ना हो जाए। और बहुत सारे प्रॉब्लम्स उसी चंद मिनट में होते हैं। जैसे हम कहते हैं फर्स्ट मिनट ऑफ लाइफ ऑफ ए न्यू बॉर्न इज़ ए गोल्डन मिनट, कि उसमें अगर हमने उसको ब्रीदिंग को हेल्प नहीं किया तो फिर बर्थ एनोक्सिया के बाद उसके कॉन्सिक्वेंसेस, मेंटल रिटार्डेशन, डिलेड माइलस्टोन्स, पुअर स्कूल परफॉर्मेंसेस। इसी तरह ज़्यादातर आपके जो मेरा ख्याल है कि जो टीयर्स हैं ये भी होम डिलीवरीज़ में ज़्यादा होते हैं। ऑब्स्ट्रक्टेड लेबर है, ब्रीच है, दाई ट्रेंड कोशिश करती है और फिर लेट रेफ़र करती है, और ये इतना हिडन प्रॉब्लम है कि बहुत सारी माएँ बताती भी नहीं हैं। और हमारा जो गांव गोट है, जो पेरीफ्रीज़ हैं, वो तो 21वीं सदी में दाखिल ही नहीं हुए, वो तो 19वीं सदी की ज़िंदगी गुजार रहे हैं, जहाँ कोई ट्रेन डॉक्टर ही नहीं है, कोएक्स चला रहे हैं, डिस्पेंसर चला रहे हैं। तो मेरा ख्याल है कि अगर हम होम डिलीवरी को डिस्करेज करें, और जैसे सिंध हेल्थ केयर कमीशन कर रहा है कि जो कोएकरी को और जो मैटरनिटी होम्स हैं जहाँ इनकॉम्पिटेंट लोग प्रैक्टिस कर रहे हैं, तो प्रिवेंशन इज़ बेटर देन क्योर। तो हम इसको प्रिवेंट भी कर सकते हैं। जो हो जाए डेफिनेटली उसको तो उसको ट्रीट करना पड़ेगा, और उसके लिए एक्सपर्ट लोग मौजूद हैं। तो मेरा ख्याल है कि हमें जो अपनी 50% डिलीवरीज़ हैं जो इनकम्पिटेंट लोग कर रहे हैं उसको भी प्रिवेंट करना पड़ेगा, उसको डिस्करेज करना पड़ेगा, और हमें अपनी पेरीफ्रीज़ में, रूरल एरियाज़ में ये फैसिलिटीज़ को बढ़ाना पड़ेगा। मेरा ख्याल है वहाँ बहुत सारे केसेस तो ऐसे होंगे जो रिपोर्ट भी नहीं होते होंगे, सिटी में तो रिपोर्ट हो जाते हैं ये। तो हमारे जो फिगर्स हैं वो भी एक्चुअल फिगर्स नहीं हैं। बहुत सारी मैटरनल डेथ ड्यूरिंग कन्फाइनमेंट रिपोर्ट नहीं होती, बहुत सारी नियोनेटल डेथ घर में प्रीमेच्योर बच्चा हो गया रिपोर्ट नहीं होता। तो हमारे एक्चुअल फिगर्स इससे बहुत ज़्यादा होंगे। तो हमें बहुत ज़्यादा काम करने की ज़रूरत है इस एस्पेक्ट पे। एंड थैंक यू वेरी मच फॉर लिसनिंग मी।
Thank you, sir. We are honored to have our chief guest, Vice President of Pakistan Urogyne Association, Professor Dr. Haleema Hashmi. She has worked in many renowned hospitals like Civil Hospital, Bakai Medical Hospital, and she has also worked as a head of a department in Liaquat Medical College Hospital. I would like to call Madam on stage and share her views and experience with us. Thank you.
शगुफ्ता मेरा लेक्चर प्लीज़ लगवा दीजिएगा. अच्छा चलिए. बिस्मिल्लाहिर्रहमानिर्रहीम. अस्सलाम वालेकुम. First of all, I would like to thank Dr. Shagufta and the administration of Hussain Lakhani Hospital for inviting me here and giving this honor to be as a chief guest. I don't think I deserve that. I'm a clinician and remains as clinician and colleague with Dr. Shagufta. Dr. Shagufta से मेरा बहुत पुराना association है. She has been my student also as Dow Medical College, and then we have been colleagues at Liaqat National Medical College and Hospital, and although she left Liaqat National, but still we are in close alliance with each other, and we have very good relationship, and she has been working a lot for Urogyne Association and for the betterment. At the moment, we are more concerned about the morbidity rather than the mortality, right? Mortality just finishes, but morbidity continues to affect the women for the rest of her life, which is, I think, more discomforting and more annoying to live with a deformity or with a problem, right? So most of the time, we like to prevent all these things in order to give teaching to our juniors how to conduct and how to avoid these morbidities. So today's topic is mainly related to the defects of the anal sphincter and how we can repair it and how can we diagnose it. मेरी कहाँ है? वो हम साइंटिफिक सेशन अच्छा साइंटिफिक सेशन में करेंगे टी ब्रेक के बाद. अच्छा उसके बाद है. ओके ठीक है. I thought के बस आप. So I think as I thought I was going to start my presentation on the perineal tears, anatomy and related things, but we will have, I think, in the next session. So I'm very thankful that they have invited me here, and I hope that this session is going to be informative for you, both theoretically as well as when you see the procedure being done, videos as well as on the animal models. So thank you very much for inviting me, and we hope it's a good session. Thank you.
Thank you, madam. Now I would like to invite Dr. Ayesha Abdul Razzaq, Associate Professor, OBG Department, Hussain Lakhani Hospital. Please, madam, come on stage and give brief introduction of our hospital and its facilities.
I will request our guest and chief guest, guest of honor, please come and seat over here so that
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Ayesha Abdul Razzaq and I am Associate Professor in OB-GYN Department. I will give you a brief introduction of our hospital and the services we are providing. Hussain Lakhani Hospital is affiliated with Iqra University. It is a 350-bedded hospital. It is a state-of-the-art hospital and covers a huge area of about 200,000 square foot. We have all departments. So we have, alhamdulillah, all the departments working in their full capacity. For example, medicine and allied, surgery and allied, obstetrics and gynae department, pediatric department, and other associated departments as well. It is recognized by different bodies, for example, Sindh Healthcare Commission and others as well. So here we see medicine, surgery, pediatric, OB-GYN department, and their allied specialties as well. These are our other departments: anesthesia, radiology, accident and emergency. In medicine and allied, we have neurology, cardiology, pulmonology, gastroenterology, dermatology, surgery and allied with all its specialties. If you can see, this is our reception area, is quite spacious, comfortable. This is our emergency ward, our labor room.
gynae operation theatre, dedicated gynae operation theatre, I would like to say. This is our PEDS ward. We have an ICU facility all the time, round the clock. So these are other, if you see, this is our ICU, equipped very well. Our general ward. We have semi-private and private room facility as well. These are other departments. We are providing 24/7 emergency services. Trained doctors and staff are on duty round the clock to serve the patients. The labor room operation theatres are well equipped with latest machines and instruments. Besides this, we have ICU and ICU facility all the time. In addition, we have radiology, laboratory, pharmacy and blood bank service round the clock. At the end of the workshop, we invite you all to please visit the hospital with us and see it by yourself, and then you can give us your feedback as well. You all are welcome again. Now it is that I will call Dr. Gulnaz to please come onto the stage.
Now I would like to request Professor Dr. Muhammad Masroor, please sir come on stage and present the bouquet and the shield to Dr. Professor Haleema Hashmi. Chief guest, Professor Dr. Haleema Hashmi. Please, madam, come on stage and receive your memento and bouquet from sir. तो कर दो. Thank you, madam. Now I would like to request Professor Dr. Shamim to receive his memento and bouquet from Professor Dr. Masroor. Thank you, sir. I would like to request Professor Dr. Muhammad Hanif, please sir come on stage and receive his momentum and bouquet from sir. Thank you, sir. Now I will like to request Professor Dr. Haleema Hashmi, our chief guest. Please, madam, come on stage and present the memento and bouquet to Dr. Professor Masroor. Sir, please. Now I would like to request Professor Dr. Masroor. Sir, please come on stage and give present to memento and shield to Dr. Professor Dr. Shagufta Tahir.
Thank you very much, all our chief guests and guest of honors and all of the participants who joined us today in very beautiful weather. In fact, today's weather is very romantic. We should have the pakoras here, but we have arranged some sort of the refreshment for all of you. I'm also thankful to the people जो background में काम करते हैं और जिनकी वजह से आज हम यहाँ एक महफिल सजाते हैं पढ़ने पढ़ाने की, और वो हमारे pharmaceutical के friends होते हैं, and they are always standing with us. हम जब भी कुछ करना चाहते हैं, doctors, they help us. So I'm thankful to Ethicon. They are the people who arranged the models for us, and they arranged the switchers and everything and all the support regarding that. Then Global Pharma, they came and they organized this Zoom facility for us and the other related things. And the other pharmaceuticals, they are also here, and like HiQ, and they are here to bring the doctors and spread the information what we wanted. So we are thankful. And yes, very important. So we have our very active and smart hospital staff, in which I would like to specially thank Mr. Munib Saab and his team, IT, Mr. Omar and his team, and then Dr. Nazia being the administrator, and she was very instrumental and she was very helpful to all of us, and she was here and she did everything in the background, and likewise the other staff who is working with us. And yes, the last but not the least, my team, I'm really thankful to Dr. Gulnaz. She's a senior registrar working in the OBGYN department, and Dr. Ayesha Abdul Razzaq, and she is the associate professor, and Dr. Faiza Khamisa, she is our registrar, and one of the registrar, she is in the night, she's here, Dr. Naseem. So and Dr. Iram, yes. Dr. Iram is our registrar in the morning hours. So I'm thankful to all of these doctors. They have worked in collaboration, and in fact they worked in the busy schedule of their life and the patients and all that, and along with that the organization of this workshop. So I'm really, really thankful to all of them. So they helped me, and I'm thankful to the participants as well. They have joined us, and I hope inshallah it is going to spread the word what we want to spread. Thank you very much.
Thank you, madam. Now it is time for a short tea break, after which we shall to proceed our scientific program. Thank you all, and take your teas.
Again, Bismillahirrahmanirrahim.
I would like to invite Professor Dr. Haleema Hashmi. Now we will proceed our scientific session, and I would like to invite Professor Dr. Haleema Hashmi, Vice President of PUGA. Madam, please come on stage and convey his experience and give her a brief lecture on the anatomy of a perineum and anal canal.
Thank you very much. So now we're back to work again. I think we all been refreshed with good tea. So we are going to start now a little bit boring topic, but I think it's going to be useful when you repair or when you apply it on the patients. So as Dr. Shagufta said, that the majority of women aims to have a normal vaginal delivery at the end of a normal pregnancy. But there are some percentage of the patients or the women are such that they will not be able to achieve it, right? So the trauma that occurs at the time of the delivery is not only related to that particular period, but it is going to have a very long effects. and then they see these effects after the age of 45 or 40. So it's very important that when we conduct the delivery, we conduct in such a way that we protect all the supports of the pelvis and vagina. Okay? So today's my topic is anatomy of the perineum and anal canal. This is the Liaqat National Hospital where I worked, and mainly I will discuss the prevalence of the perineal tears, what are the risk factors, classification, and mainly how you will understand, which is difficult. Majority of the people do not like it as interesting topic, but it is very important to know the basic anatomy, otherwise you will not be able to work properly. Then the perineum and its boundaries, pudendal, anal canal, and then what is the anal sphincter injury, and what is the mechanism of anal continence. So prevalence actually varies from country to country. More than 85% women sustain some form of perineal trauma, even in UK, but the risk of AOCs is much less compared to our country. Episiotomies at one time used to be the norm, and in Netherlands 80%, in England 14%, 50% in USA, and 99% in Eastern European countries. Frequency in Pakistan of perineal tears has been assessed by 3 authors. Initially, in the year 2007, there was a study which has suggested that the incidence of perineal tears in Pakistan is 9.5, and the mean age is 27 years. Later on, another study suggested by Rizvi from JPMA that frequency is 0.5%, and the majority of the patients were nulliparous, and 50% of them have a forceps delivery. So the instrumental delivery actually increases the risk of the perineal tears. Then the latest study was in year 2021 by Rahila Mohsin and Sadia Abrar, and in this they have actually make an audit of what they did 10 years back, and then they repeated this audit to find out whether the incidence has decreased or increased. And in this they found out that the 3rd and 4th degree perineal tear, out of 25,370 deliveries over the 10-year period, they have found the incidence has reduced to 0.56%, which was initially 2.8%. So mainly improvement in practices has led to decrease in the incidence of the perineal tears. Perineal tears, I'm sure you all know, the 1st degree is the one which is laceration of vaginal epithelium or perineal skin only. 2nd degree may involvement of perineal muscles, but not the anal sphincter. Or 3rd degree is disruption of the anal sphincter muscles, which should be further divided into 3A, 3B, and 3C. 3A may less than 50% thickness of the external sphincter torn. In 3B, more than 50% of skin thickness of external anal sphincter torn. In 3C, internal sphincter also involved. And in 4th degree tear, there is a 3rd degree tear with disruption of the anal epithelium, or a hole in the anal canal. This is just the diagrammatic representation of the different types of perineal tears. Pointer nahi hai. You can see that the muscles which are coming is the, koi pointer hai kya? Bahral, it is, you can see that the important muscle is the puborectalis. This is the puborectalis, which is just the above the external anal sphincter. And in usual episiotomy, we just go up to here. This may be torn. But when we say that it is an external anal sphincter, these are the 3 parts of the external anal sphincter: deep part, superficial part, and the subcutaneous component. Whereas the internal sphincter, thank you. Internal sphincter is the thin part, this is external sphincter, usually is a muscular portion, whereas the internal sphincter is the end of the bowel mucosa, and it is thin and it is subcutaneous fatty tissue. Okay. And then you can see this is the anal orifice, right? So how do we evaluate patient with perineal trauma? Vaginal examination after delivery for tears in vagina or rectum in good light, and also per rectal examination. This is very important, that after every delivery, when you have completed the episiotomy or even not episiotomy, still it is better to do PV and PR when you are shifting the patient to the, from the labor table to the recovery area or to the ward. Okay. Suture as soon as possible after childbirth to avoid excessive blood loss and minimize the risk of infection. Transfer to OT, particularly if you are suspecting third-degree tear. Then it should not be stitched in the labor room, it should be stitched into the OT under general anesthesia and with good light. Check equipment, count swabs and sponges before and after the procedure. Good light in the labor room to identify structures properly and extent of the injury, and then catheterize the patient for 24 hours to prevent urinary retention after you have done the repair. Usually majority of our doctors who are residents may require senior help, so it is better to ask your senior help if it is beyond operator's scope of practice. If you think, if you are Air 4 resident or SR, you think that you need a consultant to come, then please call them. And close the dead space to achieve hemostasis and to prevent hematoma formation. Sutures not to be over tightened may cause tissue hypoxia. Ensure good approximation and anatomical alignment. So we are going to the anatomy now, so that you know what is the anatomical alignment means, that all the anatomical structures should be approximated to each other. And then count swabs and sponges. I am saying again and again, because sometimes patient comes after 1 week or 2 weeks and they have a swab left inside, which destroy your surgery and causes infection. So what is the pelvic floor or the pelvic diaphragm? It is the muscular diaphragm which is concave superiorly, and it separates the pelvic cavity from the perineal space. It is formed by levator ani and coccygeus muscles covered by the parietal layer of the pelvic peritoneum or pelvic fascia. There are two gaps in the pelvic floor or pelvic diaphragm. The anterior hiatus is urogenitalis, which transmits urethra, vagina, and which is bridged by pelvic fascia, which is the urogenital diaphragm. Then there is a hiatus rectalis, which is the posterior part, and it transmits rectum and anal canal. The components of the pelvic floor are mainly pubococcygeus, iliococcygeus, and ischio-coccygeus. These are the three important muscles which forms the pelvic floor. The functions of the pelvic floor are, it maintains intra-abdominal pressure. During labor, responsible for medial rotation of the head, of the presenting part, whichever it is, but mainly head, for directing it downwards and forwards along the birth canal, usually at the time of crowning of the head. The last two muscles stabilizes the sacrum during the process of labor and support of the vagina and rectum like a sling and as a sphincter of the rectum. The ischio-coccygeus and iliococcygeus. Pubococcygeus is the upper part. Then the perineum is an external surface and is a shallow compartment of the body. The perineal compartment lies inferior to the pelvic outlet. If you remember your anatomy, that the pelvic outlet is where you see the pubic arch, right? So pubic arch ke niche ka jo portion hai, that is the perineum, and is separated from the pelvic diaphragm by perineal membrane. The boundaries of the perineum are pubic symphysis anteriorly, inferior pubic rami and ischial rami anterolaterally, ischial tuberosities again laterally, sacrotuberous ligament, which is the ligament which goes from the sacrum to the sacroischial tuberosity, which is called the sacrotuberous ligament. Inferior most is the sacrum and coccyx. These are the bony parts. A transverse line joining the anterior ends of the ischial tuberosities divides the perineum into two triangles. The anal triangle, which contains the anus and is posterior to this line, and the urogenital triangle, which contains the root of the scrotum and penis in males, and the external genitalia in females, which is anterior to this line, जो कि join करिए दो ischial tuberosities, if you remember your anatomy of the pelvis. Actually, I forgot to ask Dr. Shagufta to have a bony pelvis so that we can understand. But in this diagram, you can see this is the ischiocavernosus muscle, okay? And then the bulbospongiosus, then superficial transverse perineal muscle. This is the anterior hiatus, which contains urethra, vagina, and then this is the posterior, where is the anus, and at the junction of the anterior and posterior hiatus is this is the portion where we have the perineal body, which is the most important structure we are coming to it, right? And the external anal sphincter is this one. So perineal body is an irregular fibromuscular mass located in the median plane between the anal canal and the perineal membrane. It contains collagenous and elastic fibers and both skeletal and smooth muscles. It is a site of conversion of several bundles, as you just saw: bulbospongiosus, external anal sphincter, superficial and deep transverse perineal muscles. The muscle which was going in the previous is the next diagram. The perineal body lies deep to skin and anterior and subcutaneous tissues and posterior to the vestibule of the vagina and anterior to anal canal, as we just saw in the last diagram. It is attached to posterior perineal membrane and it is the final support of the pelvic viscera. During the birth, actually, this is the perineal body which gets damaged and which leads to prolapse in the later life. As you can see in this diagram, this is the fetal head which is pressing on the perineal body. This is usually at the time of crowning of the head, you can see. क्या हुआ? चाहिए इसको छोड़ दें जी. Pointer. It's okay. This is the, it's all right. This is the, you can see that this is the head, right, of the baby at the time of the crowning. ये क्या है? हाँ, ये नेक्स्ट का है. नेक्स्ट का नहीं, इसमें सिर्फ पॉइंटर है. अच्छा, ठीक. ओके, ये पॉइंटर है, ये नेक्स्ट है. अच्छा, ठीक. ओके. So the applied aspect of it is we come back to the same picture. Actually, this is very important to understand and these structures, that it is actually at the time of the crowning of the head where you need to give the proper support. If you don't give proper support at this time, then it can lead to the damage to the perineal body is unavoidable, but it also leads to the damage to the other muscles which are important later on in causing the rectocele and cystocele in these patients. So it is very important that you can see that the important muscle levator ani is also these are the levator ani muscles, these are the bulbospongiosus muscles, right, and the incision of the perineum here you can see. At this point we have a perineal body, and then the perineal body is the one which is likely to get damaged. These are the portions of the external anal sphincter. This is sacrum and this is the anal portion. Okay. The applied aspect is that stretching and tearing occurs during childbirth. Posterior vaginal walls support and get damaged and lead to prolapse of the vagina. Also, the trauma or inflammatory diseases can affect, infection can lead to anovaginal fistulas. So, attenuation of perineal body associated with diastasis or separation of the puborectalis muscle, which can lead to rectocele. So, all these are the effect of the unsupported vaginal delivery. If we give a proper support during the second stage of the labor, then these traumas we can avoid. But there are some changes which you cannot avoid. Some damage to the muscles definitely occur with the deliveries. What is episiotomy? Episiotomy is actually a deliberate cut that we give in order to enlarge the introitus. And vaginal birth compromises and continence mechanism of the direct injury to the anal sphincter, puborectalis, sling, and perineal muscles and perineal fascia can be avoided by giving an episiotomy. Episiotomy जो है वो perineum and the lower posterior vaginal wall करते हैं. There are two types of episiotomies which we are going to discuss. It's mainly protects and supports the vagina and also the perineal body, which is the major structure which is incised. But if it is incised properly, it is likely to be approximated properly. But in an irregular tear, it will be difficult to approximate the perineal body in order to avoid the prolapses. So, purpose of episiotomy is two major objectives: protection of the fetal head from prolonged pounding on a resistant perineum, and number two, protection of the maternal tissues from irreversible damage during descent and delivery of the head. Medial lateral episiotomy lowers the risk of anal sphincter injury, whereas midline episiotomy is associated with severe lacerations and anal sphincter injury. That is why recently the trend is whether the episiotomy to be done or not to be done. And quite a lot of countries, and even in England, episiotomies are now not done very commonly as it used to be for every delivery, and they think that if the episiotomy is given by a junior person, it is more likely to damage their external anal sphincters and internal anal sphincter rather than the protecting it. So it's more traumatic rather than preventive. So that is why it is important to assess whether the patient needs episiotomy or not. Usually in primigravidas, you do need episiotomy in order to prevent, but multigravidas, and if the baby is not too big and the position is proper, you don't need to give episiotomy in each and every patient. And there has been debates in different conferences whether to give episiotomy or not to give episiotomy, advantages and disadvantages. Forceps में ज़रूरी है, any instrumental delivery we should give episiotomy. Now we come to the little bit more anatomy. Superficial perineal pouch, it contains superficial transverse perineal muscles, branches of the internal pudendal vessels, branches of the pudendal nerve, root of the clitoris and the muscles associated with it, bulbs of the vestibule and the surrounding muscles, related vessels and nerves, and all these are above the superficial perineal membrane and greater vestibular glands. Deep perineal pouch जो है, it is below the perineal membrane and it contains part of, usually deep perineal pouch is anterior and the superficial perineal pouch is lower. So deep perineal pouch contains part of the urethra, external urethral sphincter muscles, bulbourethral glands, deep transverse perineal muscles and related vessels and nerves. Proximal part of the urethra also in this, and external urethral sphincter muscle, deep transverse perineal muscles, they all are in the deep perineal pouch. Then we come to the more lower part, which is the ischioanal fossae, which are likely to be damaged in fourth degree perineal tear. So ischioanal fossae जो हैं, their boundaries are laterally by the ischium and the inferior part of the obturator internus, covered with obturator fascia, medially by the anal canal to which the levator ani descends and on which the external anal sphincter surrounding the anus. Posteriorly by the sacrotuberous ligament and the gluteus maximus muscles, anteriorly by the external urethral sphincter and the deep transverse perineal muscles and their fascia. These parts of the fossae superior to the perineal membrane are known as anterior recesses of the ischioanal fossae. Then the pudendal canal is also very important to recognize when we are operating for 3rd and 4th degree tear. It is a space within the obturator fascia which covers the medial aspect of the obturator internus and lines the lateral wall of the ischioanal fossa. The internal pudendal artery and vein and the pudendal nerve and the nerve to the obturator internus enters this canal at the lesser sciatic notch, which is inferior to the ischial spine. Do you remember which is the lesser sciatic notch? There are two, if you remember the pelvic, bony pelvis, ऊपर वाली जो होती है वो greater sciatic notch है, the lower one is the lesser sciatic notch. And when we give the pudendal block to these patients before instrumental delivery, then you will have to, you pass a needle either internally through the vagina or externally between the ischial tuberosities and the anal orifice के mid point पे अगर आप needle अंदर push करेंगी तो then you should touch the ischial spines, right? Because the pudendal nerve hooks around this, in the pudendal canal is going there and the pudendal nerve is hooks around the ischial spine. So when you give the local anesthetic there, then this portion of the patient gets anesthetized, or patient will not feel the pressure of the applying blades of the forceps or vacuum delivery or breech vaginal delivery. In all these situations, we have to give the pudendal block so that the patient does not feel the pain of, it's a very hard metal thing which goes inside. Okay? Pudendal nerve supplies most of the innervation of the perineum. Towards the distal end of the pudendal canal, the pudendal nerve splits and giving rise to the perineal nerve and continue as the dorsal nerve of the penis in male or clitoris in the female. These nerves run anteriorly on each side of the continuation of the internal pudendal artery. So this area is very vascular. That is why it is very important when you are operating in this area that you should maintain hemostasis. अगर हम hemostasis proper नहीं maintain करेंगे तो after you have done the repair, there may be hematoma formation, because there is a very rich blood supply in this part which is we are repairing in 3rd and 4th degree tear. Anal canal is the terminal part of the large intestine and that extends from the upper aspect of the pelvic diaphragm to the anus. The anal canal is 2.5 to 3.5 centimeter long, begins where the rectal ampulla narrows at the level of the U-shaped sling formed by the puborectalis muscle. The anal canal ends at the anus, the external outlet of the GIT. Anal canal is surrounded by the internal and external anal sphincters, descends postero-inferiorly between the anococcygeal ligament and the perineal body. Anal canal is collapsed during the passage of feces, but both sphincters must relax before the defecation can occur. These are the different parts of the external anal sphincter. These are the subcutaneous bulbocavernosus muscle you can see, and these are the transverse perineal muscle. This is the internal anal sphincter you can see, which is the thin, how you identify during the repair, because it is pale yellow color and this is a muscular color, reddish brown color. ठीक है, so external anal sphincter ये वाला है जिसका brown color है, और internal anal sphincter ये है जो कि fatty yellow color है, ठीक है, because it is the continuation of the GIT or anal canal. This is during the surgery how you feel, because usually the external anal sphincter after damage during the delivery, they get retracted. So it's very important when you are repairing the 3rd degree or 4th degree tear that you must recognize the parts of the retracted external anal sphincter, because usually it separates and then you have to really look for it before you start repairing. Okay? So you always try to hold with the LSS tissue holding forceps the external components of the external torn anal external sphincter, and then anal sphincter recognize, and then start repairing the for anal canal. So because you are going to repair the anal canal first and then you will go to the external sphincters. But recognizing them, because sometimes they may be very close to the anal trauma, so you may not be able to, you have to approximate external to external and anal to anal. अगर आपने एक्सटर्नल को अलग से नहीं किया या फर्स्ट 3 पार्ट्स हैं एक्सटर्नल के, उनको ईच पार्ट को एक दूसरे के साथ अप्रॉक्सीमेट नहीं किया, तो दिस रिपेयर इज़ नॉट गोइंग टू बी वेरी इफेक्टिव. So puborectalis muscle जो है, it is a striated muscle, medial portion of the levator ani, that is responsible for maintaining and increasing the anorectal angle and contributes to the squeeze pressure in the anal canal. You can see the perineal muscles in the 3rd degree tear which are being torn, and the anal sphincter. In 4th degree tear, you can see that the anal mucosa is also damaged, the anal sphincter. This is the rectum, and these are the external and internal anal sphincters torn. Defects of anal sphincter: internal anal sphincter continue incontinence results in insensible fecal incontinence. External anal sphincter incompetence causes fecal urgency. 3rd degree tear reported in 2.8% of primary gravidas and 0.4% of multigravidas. Ultrasonically, we can also diagnose them. They are visible anal sphincter defects, and they appear in 82% of women undergoing forceps delivery and 48% of ventouse. So forceps is more traumatic compared to the ventouse delivery. So now we come to the anal continence, how anal continence is maintained, and coming to the end now. Anatomically, there are 3 controls: anatomical control, neurological, and functional. Anal sphincter mechanism, as we have just discussed, and the puborectalis sling and anorectal angle, they make the anatomical portion of the mechanism of the anal continence. Then neurologic internal pudendal innervation, as we just discussed, that they go into the pudendal canal. Anorectal reflex and sensory mechanism. Functional is a stool volume and consistency. Colonic transit time: some people, those who have irritable bowel syndrome, that their colonic transit time is less, so they pass more frequent stools. Rectal capacity, distensibility, and tone. So it varies from person to person. So this is the final algorithm of the anal continence mechanism. How does the anal continence is maintained, and what happens when it gets disrupted, and what the Dr. Shagufta is going to tell you, okay, what happens when these mechanism got disturbed. So rectal distension will give rise to rectal sensation on one side, and then the internal anal sphincter relationship will contract. Then the anal sensation will occur, and the patient will feel the desire. Then the external sphincter and puborectalis contraction, followed by muscle fatigue for 40 to 60 seconds, and then the rectal compliance occur, and then the patient passes stools. Peristaltic wave then subsides, and the continence is again maintained. So this is the whole process of how the passage of stool occurs as a result of normal anal continence. If it gets disturbed, then we are going to have the morbidity or pathology. Thank you very much. If you have any question, please, I'm happy to answer. Have you all understood, or have you all not understood? Or it's more complicated? I think to absorb the anatomy, you have to think and imagine and work, go and read back your anatomy again and again. You have to read again. Just by listening once, you will not be able to understand. जो सर्जिकल एनाटमी की किताबें हैं वो आप लोगों ने पढ़ना छोड़ दी है, वरना सर्जिकल एनाटमी इज़ वेरी इंपॉर्टेंट फॉर द एट द पोस्ट ग्रेजुएट लेवल, राइट? यू नीड टू नो द सर्जिकल एनाटमी बिफोर यू कैन ऑपरेट प्रॉपरली. ठीक है.
References.
You are very, very emaciated. They just saw the picture and they know what they are doing. Yeah. So in my understanding that it's a very good illustration. So if you get two illustration on the wall, on the side wall of the labor, and the people were doing it, or on the head side at least of the patient, so that the one who is doing a gynae obstetric, you can just look it, and then they give the incision if they want to. And the take-home message is that the examination at the end is also very important, very important.
It's very good suggestion that we should have maybe a blackboard or something on this. These things are written. The direction is given how to give episiotomy, so that the new residents who are starting to deliver, they will see these things.
Excuse me, and what instructions we are inside? And if we go deep, what damage we can.
So if you have got a photograph there, and I'm the photograph which is short, and you are using a knife to make a say for
dotted line. Yes.
episiotomy, then she said that this is the perineal tear, this is the direction of the arrow, which can give an idea. Yeah.
Median episiotomy, this is
So median has gone now, so only now we have video lateral. Yeah. So if you have that, and you can have a direction, this on a photograph of the back side. Yeah, the back side there is an anatomy, and the red line shows the how to cut it. And then she can say that grade 1 perineal tear, upper part, middle part grade 2, third is this, and fourth is this. And put your finger in the anus and the vagina at the end. So the two photographs will give you a whole of your lecture. And everyone can see that. This is when you are doing it on the back of the patient, there is a photograph.
Not forget.
Yeah. Yeah. So you see that if you're seeing it there and you are doing it alone or one body just look it up.
Thank you very much, sir. It's a very good idea. In fact, we need to improve the services as much as possible. So it's a very good suggestion to the team of OBGYN and the whole country. In fact, we are going to think about it.
The metaphorical diagram
Yes,
is very good.
you are right.
Especially one where the child is coming out and in the background the muscles are there. So
Muscles which can be done.
yeah. Thank you very much.
Thank you, madam. Very informative lecture. Now I would like to invite Professor Dr. Shagufta Tahir, General Secretary, PUGA. Madam, please come on stage and demonstrate how to repair 3rd and 4th degree perineal tear.
Assalamu alaikum, everyone. And it's not up till now afternoon. Hone hi wala hai. But the first talk, I think you must have learnt anatomy out of it. कुछ slides हैं जो मेरी और मैडम की थोड़ी सी जो ओवर होंगी ओवरलाइड, लेकिन most of the things जो मैं आपसे डिस्कस करूँगी that will clear your ideas. कि जो चीज़ आपको उसमें नहीं समझ में आई है तो you can ask again. And then we will have 3 videos on it. ठीक है ना? तो उन वीडियोस में बाकी आपका जो ख्याल है कि कैसे ऑपरेट होना है और किस तरीके से सब कुछ होना है और हाउ व्हाट इज़ द टेक्निक, वो आपको क्लियर होता जाएगा. ठीक हो गया. नाउ वी आर गोइंग टू स्टार्ट द पेल्विक फ्लोर डिसफंक्शन आफ्टर द चाइल्ड बर्थ. In fact, this is the major problem. You know, what we have in the pelvic floor dysfunction is the urinary incontinence, fecal incontinence, we have the pelvic organ prolapse, and then we have the sexual dysfunctions. These are the 4 things what we have to look after in a course of urogynecology. Right? Today we are going to concentrate onto the fecal incontinence. The most common cause of the fecal incontinence is after the childbirth. The women may have the traumatic injury to the anal canal, anal sphincter, or there may be the occult injury which is not visualized at the time when you delivered the patient, and the patient may turn up later on in her life, and she used to visit the doctors. They cannot get hold on to the flatus. They cannot control the feces. You didn't have any, if you examine, you did not find any of the problem in the rent on to the 4-degree perineal dial. But they have a problem. So what that problem is? So what we are going to discuss. These two gentlemen, Dr. Abdul Aziz, he is a urogynecologist. He is the man who derived this classification, what Madam discussed with you. And he is a president of Pakistan PUGA Internet. And she is the wife of his, and she is also a very renowned person, Dr. Rani Thakur. And I did this, I attended their book launching ceremony in 2010. So this is their courtesy. So today we are going to learn why we have the problem, what is anatomy. I skipped this part of the anatomy because Madam has covered it. Episiotomy little bit and the tear little bit, and mostly I will consider on to the postnatal, how you are going to tackle the problems after the repair of OSS. OSS is obstetrical injuries to the anal canal. Now introduction is what? Now we have the delivery since the world is made. दुनिया में बच्चे शुरू से पैदा होते चले आ रहे हैं, बट व्हाट्स द डिफरेंस नाउ जो जब नहीं था, वो ये कि ह्यूमन ब्रेन जो है इसकी डेवलपमेंट शुरू हुई एंड द साइज ऑफ द हेड इज इंक्रीजिंग. सो व्हाट दे फाउंड दैट द ह्यूमन काइंड डेवलप हिस्ट्री अगर आप मिलियन ईयर्स की उठाते हैं तो साइज ऑफ द हेड इज ग्रोन आउट ऑफ द प्रोपोर्शन टू द साइज ऑफ द pelvis. Initially, they used to have the deliveries in the jungle, wherever, there's no problem. But nowadays, the brain matter is increased, and now the human being, we know that they are more intelligent, they are working more, and now the size of the bodies of human is reduced as compared to the size of the brain. So this is a study, it was conducted in way back in 1990, and they found that this is one of the reasons. Then human labor complications increase likewise in all of the races of the mankind world over, but it is affected most in the African countries. Why? Because they are deficient in the nutrition, they have the short stature, and then they have got a problem with their childbirth. They did not have any of the facilities available. So most of the time the girls, they deliver in a young age in the home, and the delivery is unattended. Then currently the rise of the cesarean section. Because of this, so in a world which is developed, now they have the developed blood banks and antibiotics and a good anesthesia cover and all that. So the rate of the cesarean section for the safe delivery is nowadays increasing, and now it seems 25 to 30%. In China it is 60, and in our part of the world, and if you take the data from your tertiary care wards and hospitals, you will find it's more than 45 to 50% of the deliveries they are with the cesarean sections. So initially the human being, they were like that, they didn't have a much brain. So with the passage of the time, this is the human brain teacher, you can see how they are developed now. So there is a discrepancy. So what is it? They think the large head and the small pelvis. So this creates our reproductive problems. Dystocia of the labor. That's a complication of the birth process. It's a difficult labor. So 95% of the time, this difficult labor end up onto cesarean sections. So what happened to the obstructed labor? After the end of the obstructed labor, there is the morbidity, definitely. Either the women will have the prolapse, the later age, she may have the fistula, which is very common in the Nigerian countries. And we, nowadays, we are having more, not that is the obstetric fistula, that is the iatrogenic fistulas in Pakistan. So what is the conflict between the mother and the baby? For the mother, the baby should be the smaller one, easier to deliver, but for the baby, if a baby is small, they will have the respiratory distress syndrome. So large baby have the low perinatal mortality, but causes the problem for the mothers. You know, vesico-vaginal fistula with the mother, and there's a chance of having the prolapse, then stress incontinence, fecal incontinence increase in the maternal mortality rate. That is the problem with the mother can occur. And the babies, if the babies are small, they are very easy to deliver, there's no problem, but they do develop this, if they are preterm, they may have the respiratory distress syndromes, they may have the hypoxia, acidosis, leading to the problem if they are IUGR. And then they may have the hypoglycemia and hypothermia, and there's an increase in neonatal mortality rate. Then we invented the episiotomy. So episiotomy is what? It is basically periotomy. You can see that is, by definition, it is the surgical enlargement of the introitus made with the scissors or the scalpel. So it is the most unkindest cut of all. You destroy the normal perineum, cut them with this. But if you don't cut, it is going to damage, and that damage with the head of the baby will bring more complications and the problems. And when we were young, we were taught by our professors that if you give the clean cut incision, it's very easy to repair in a same alignment. The patient will not have the problem rather than a tear. If the person is having a tear, aap dupatte ko bhi phad ke dekh lein, it will become ragged. So if you start stitching them, it is difficult. So the background, so that's why it's the periotomy. And it was introduced about 260 years ago, and it facilitates to facilitate the delivery. This was the aim and objective. And this is to prevent the severe perineal tears, which may become very difficult sometimes to stitch them. It was not widely used until the beginning of the 20th century. Then by 1930s, it became routine in American hospitals, and then 1950s widely it was used in UK when the women were encouraged to deliver in the hospitals. Initially they used to deliver at home. Nowadays again they are reverting back and they ask their women to deliver at home, and they provide the ancillary services to the women at the home, at their doorsteps. And by the 1970s, up to 91% of the UK hospitals, they had hospital deliveries. And 2001, the rate is reduced again in the England to about 14%. So they are reverting back. Diverse rate introduced without the scientific evidence. So what we can think that what is the benefit of having the episiotomy or periotomy? So postulated benefit for the episiotomy is, now it prevents the severe perineal tears, and it preserves the perineal muscle function and improves the sexual functions later on, and reduces the risk of the fecal and the urinary incontinence. So it will straight, clean cut incision, very easy to stitch, and there will be less chance of having the later on complications, and it is less painful and it is better. But the risk which is associated with this episiotomy is it may involve the external anal sphincter if you will not give the good support to the episiotomy. If the alignment of the episiotomy is not good, then even you can extend to that in the midline, and that is going to damage weakness of the pelvic floor structures, and it also increases the sexual problem. And in the part where we are living, we are having the women, they are deficient in the nutrition. Yesterday, I operated one of the patient, and she is an old woman, but when I opened her abdomen, I found her muscles, they were so weak and thin. And I came to know that her nutritional status in the life must not be, she's happy with the meat eaters. I asked her today, मैंने कहा जी आप क्या खाना पसंद? कहती ज़िंदगी भर डॉक्टर साहब मैंने कभी गोश्त नहीं खाया. मैंने क्या आपके मसल्स बता रहे थे. When I touched your abdomen, I was doing the hysterectomy. तो उसके जो rectus abdominis था, it was so ballooned out. और उसको difficult था उसको पकड़ना, वो हाथ में से निकल के जा रहा था. So this is very important. We should encourage our women to take the meat. They should take meat so that they can get enough collagen which can give the strength to their pelvic floor. So this is one of the reasons the women, they are nutritionally deficient. More difficult to repair, it causes more pain and bleeding. If somebody who is not expert in doing that, so there's a chance that this will end up onto having the more problem later on. So increases the risk of infection. Infection is very common in our part of the world. That is because of the less immunity and having the bad nutritional status of the person. Interferes with the breastfeeding. So the women, they do not lactate to their babies. So this is also a very big problem. They cannot sit straight with the baby, and they just tilt, and finally they start excusing. So what is the indication of the episiotomy? When we should perform the episiotomy? So it aids the delivery, we know it. It is a rigid perineum in some of the cases of the primary patients. So it can delay the second stage of the labor, and it reduce prolonged pushing in some of the cases, like cardiac patient hai, eclamptic hai, and where you do not want, or you want to apply the forceps, you want to apply the vacuum, so there you need to apply the episiotomy. And you want to accelerate the delivery in a cases where you feel the fetus is compromised. Then prevent the severe perineal trauma during the instrumental delivery, as I said. Selective cases of the shoulder dystocia, when the baby is big, in a cases, macrosomic babies, is a chance the women can get, even it's a third, fourth, or even that sixth or seventh delivery. So you may need to give the very good episiotomy to prevent the shoulder dystocia. So there is no absolute indication for the episiotomy. Nowadays, what the West have started, they started doing the perineal massage. You know, perineal massage, it softens the muscles, which is very rigid perineum, so that the woman, by the time she reaches to the time of the delivery, the perineum becomes soft. And they simply just take the baby's head out. So they are reverting back from the episiotomy. So they have got more trained midwives who are doing their duty very dedicatedly. So current recommendations, what are these for the episiotomy? So episiotomy should not be performed routinely, pehli baat, during the spontaneous childbirth. Sometimes the perineum is very good, the baby can be pushed up. You may have seen it, it's very easy. But you just need to give the support to the perineum and then it will come out. And if it is required, then give the right mediolateral episiotomy, and it should be made in an angle of 45 to 60 degrees to the vertical axis. This is recommended by WHO. Perform only if there is a special clinical need of it. And it should not be offered routinely at the vaginal birth. Even you can give the chance of the delivery to the third and fourth degree, any OSS. If you have repaired, you can give the chance the women to the deliver. And if you need to give the episiotomy, give the episiotomy. If she can deliver without episiotomy, even they conducted a study and they said that lady can also deliver without episiotomy. But you know, there is a study I will share with you. Angle of the incision between the delivery and after the repair. Now, prospective study to assess the relevance of the suture angle when evaluating the incision angle of the mediolateral, they took the 50 women and in which the first delivery occurred, and the finding they found that initially the angle of the episiotomy incision significantly it was different than the repair. They gave the incision, and when they repaired the incision, the angle was changed. So recommended suture angle should be 40 degrees, lead median suture angle of about 5 degrees. So the incision angle of 40 degree is probably too acute to prevent the sphincter damage. So initially they cut in a different angle, and when they repaired, so it shifts to the midline. So they think that the 60 degrees is far better as compared to 40. Now the technique of repair of the episiotomy. This is the basic thing. Our students, postgraduates of the OBGYN, they start doing this operation. This is the first operation they learn in their life. And unfortunately, it is not taught by the seniors, it is taught by their own senior. One postgraduate teaches to the other postgraduate. One of maybe the PG is teaching to the house officers. So this is a very important operation, and it should be given a due respect and care, so that the women can have later on life, which should be comfortable. So practitioners, they should be skilled to carry out the repair using the continuously non-locking. We were taught that you should repair with the locking. Now they think it should be continuous without locking. No locking should be done. All layers, including the vaginal epithelium, then the muscles, and then the skin, everything without locking. So Vicryl Rapid 2.0, it's very good material. It is having a good strength, and it will absorb after the 15 days. And it has less chance of creating the infection. So episiotomy training, it should be given to the residents and the house officers, so that whenever they perform, they must learn, they must be doing the best way. So what are the issues Issues are the commonest surgical procedure worldwide, this is the one, and less experience, lack of the training in the technique of the positioning of the incision, and inconsistency in categorization, definition of the mediolateral episiotomies. जब आप mediolateral करके उसे categorize करते हैं, everybody has got a different opinion. नहीं ये इसको कहेंगे, नहीं इसको कहेंगे. So this is the way how you are going to repair this episiotomy. It's all the 3 layers, they are all without a looking. Now coming to the perineal tears, and prevalence of the perineal tear, they say more than 85% of the women stain some kind of this perineal trauma after the vaginal delivery in UK, and this is the data of the UK because I took all of them. This was a presentation, it was given by them. So England, in the England they say 14%, 50% in USA, and 99% in the European countries. So classification, madam, she discussed with you. That's the first is the first degree. It is the disruption of the vaginal epithelium. Second degree, involvement of the perineal muscles. Third degree, it has a muscle which is more than 50%, less than 50%, and then internal sphincter, it's torn. And the fourth degree, you will have the complete disruption. ठीक हो गया? And this is the depiction of the same. And this is what is it? This is the ultrasound probe. Ultrasound probe in the rectum, which suggests you which part of the muscle is damaged and from where it is damaged. So this can give you. So the perineal ultrasound and the rectal ultrasound is very important to find out the place where this damage has been occurred. So the obstetric anal sphincter injury, 29% of the women, they had the ultrasound evidence of postpartum trauma after the vaginal delivery. Otherwise, there is no evidence. The patient has no complication, no problem. They just discharge home. But 29% of the women, they did have the problem, which you can pick onto the scan. Why? When they will come to you, especially to the surgeons, they used to go, when they cannot get hold of the flatus and the feces most of the time. And especially if it's a liquid stool, they just get incontinent. So 11% involved in the external anal sphincter. They had some sort of the injury over there. 20% they involve the pubo-inalis muscles, and 7% involve the transversus perineal muscles. So external anal sphincter was associated with a significant decrease in the squeeze pressure. It's very, very, very important. General surgeons, they are very much aware of it. But the gynecologists need to learn that our index finger, this index finger should be sensitized enough to feel the anal sphincter pressure. Do the rectal examination for our patient and ask them to squeeze. So you can find how much the useful is their anal continence. So if there's a good sphincter tone, you will have the good sphincter pressure. So this means the patient is well continent. If somebody is having a weak pressure over there, squeeze pressure, it means this person is going to get the anal incontinence later in life. Or maybe there is something which is damaged. You may go for investigation of that part. Maybe there is some occult injury which you may not have up till now recognized. So a significant decrease in the squeeze pressure and increase in the incontinence score, this is something which is important. So tears to the puborectalis or the transversus perineal muscles only did not affect the pressure or the incontinence process. So when this tear should be repaired, ये भी बड़ी अहम बात है. Some of the people they think कि जिस वक्त tear हुआ है ना उसी वक्त आप repair कर दें. Most of the time the deliveries occur in the middle of the night. उस वक्त जो delivery करा रहे होते हैं, they are young people. Juniors होते हैं, HOs होंगे, नए नए PGs होंगे, seniors are at home, retired. अब उस वक्त अगर if they get the 4th degree perineal tear or there is a damage to the anal sphincter, so what should be done? So initially they were thought it should be repaired immediately. Yes, it should be. But if you do not have the capabilities of doing it, your experience is not that much, so please don't do it. You just pack it and keep onto the morning list, onto the upcoming operation theatre list, and ask your seniors to take care of this patient. Because once you perform this half-hearted repair, this is going to break and the woman is going to suffer all her life. So this is now said that immediate versus the delayed repair, इस पर एक study conduct की गई, and they found it was a randomized control trial. They found that the delayed repair 8 to 12 hours after the injury 6 and 12 months फॉलोअप उसका किया गया एंड दे फाउंड, यानी उसके 8 to 12 आवर्स के बाद जिनको ऑपरेट किया गया था, एंड आफ्टर द 6 months एंड आफ्टर द 1 year दे फाउंड देयर इज नो फंक्शनल डिफरेंस विद द डिलेड रिपेयर एंड इमीडिएट रिपेयर. They were all right. So increased maternal age is associated. When you will get the squeeze pressure is reduced, when you will get the person becomes incontinent, it is with the aging. When the age goes up, when you become postmenopausal, then there is a chance that the person become incontinent. So it is not related to the repair of the 4-degree tear. If it's done immediately or it's done later on after 6 to 8 hours, even after 1 month they say. If after the 1 month, you are not going to leave the patient for the 3 months. They said कि जब भी patient आती है, you can operate it, make it the sphere. So the result is very good. So inability to discriminate between the flatus and feces. This is the problem with the fecal urgency which come across after the later ages. और ये दोनों में हो सकता है. इसमें कोई sphincter का torn होना ज़रूरी नहीं है. So evaluation of the patient with the perineal trauma कैसे करेंगे? तो बेसिक प्रिंसिपल तो उसका यही है. मैडम ने 4 ये स्लाइडें मैडम की और मेरी ओवरलैप कर रही हैं. स्विचर आप करें उसी वक्त, एज सुन एज पॉसिबल आफ्टर दैट बर्थ ऑफ द बेबी, ज़्यादा बेहतर है. अवॉइड किस लिए? कि उसमें से ब्लड लॉस ना हो और मिनिमाइज द रिस्क ऑफ द इन्फेक्शन. बट इफ़ यू डू नॉट हैव द एक्सपर्टीज इन डूइंग दैट, प्लीज़ डोंट डू इट. बिल्कुल कुछ उसमें हेजिटेट करने की कोई ज़रूरत नहीं है, परेशान भी ना. एंड यू जस्ट इन्फॉर्म योर सीनियर. इफ़ योर सीनियर कैन कम ऑन द सेम टाइम, दे कैन हेल्प यू, और ऑपरेट उसी वक्त करते हैं, दैट्स गुड इनफ. If your senior cannot approach at that same time, वो सुबह में आते हैं, तो you can keep the patient on to the morning operation theatre list. Transfer the patient the OT अगर आपके anesthesia center मौजूद है, फिर anesthesia analgesia का arrangement should be done. Then again check the count swabs and everything. Good light is required because you want to know the extent of the injury. This very important tip over here is whenever you classify the tear, always classify 1 degree more. And if it is saying stage 3, then 3 it is less than 50%. You think it's less than, but classify it more than 50%. नहीं, एक step ऊपर सोचना है, so that कि you can give the good alignment and good cure. And then they say catheterize तो आपको करना ही पड़ेगा. Evaluation के लिए you need to take the senior's help, as I said. Close the dead space. मैडम ने आपको बता दिया था. Hemostasis should be secured very. Why? Because if you do not secure the hemostasis, there would be the chance of the formation of the hematoma. It will become infected, and then you will have the damage of all of your efforts. बेड़ा गर्क हो जाएगा. So the hemostasis and dead space को carefully you need to tie the bleeders and close the dead space. Switches should be tied, लेकिन इतना भी tie ना कर दें कि भाई उसके अंदर से blood supply ख़त्म हो and the patient become having the ischemic necrosis later on. Approximation should be done. आपको पता है जिस एंगल पे आपने कट दिया उसी पे आपने स्टिच करना, so that the angle of cut and after the resuturing should be the same one. Then in the end you should be very vigilant about the swabs and sponges what you used, and you should not leave it in the vagina. It's going to create a big problem. These are few pictures. I hope you can see them. मसला तो नहीं है. यहाँ पे अगर हम देखते हैं तो this is the internal anal sphincter which is not torn. ठीक है, ये इसका stage 2 है, 3 sorry, it's a stage 3 in which the 50% of the external anal sphincter is torn, but internally it's there. It's the same case over here. ठीक है ना, this is a partial tear. Arrow is showing the length of the anal sphincter. Next में हम आते हैं. यहाँ पे this is the retractor. If with the retractor you can see that the 3rd degree tear with the grade 3C around the anal. ठीक है, 3C. Okay, and this is the same picture in which you find after the forceps delivery you can see the capsule and you can find the intact internal sphincter. This is the endoanal ultrasound. What you saw, the probe was there in the anal canal. If you take the picture of it, you will find that this is the place where it's a damage. You know, if you have a damage, you will find the space where the echogenicity is lost. You can see in this picture more clearly. See. Arsnologists, they need to be trained in it, and I'm trying to take any snologist for myself who can be trained in it. And I would prefer that that girl, she should go to some other place and try to learn this three-dimensional ultrasound done for the perineal tears. And see, this is the occult injury in the internal anal sphincter. I called Dr. Musarrat in my conference, when we had one of those lecture from very nice and lecturer from the Sydney. And he came, in fact, he was late, but he said he's doing the perineal ultrasound. But the perineal ultrasound needs more to be done so that it should be very much valuable. So what is the principle and technique of the 3rd and 4th degree perineal tear? Repair of the varices, it should be conducted by the doctor formally trained in it, number 1. Then should be conducted in a theatre with a good light, general anesthesia. And the principle is again to find out the full extent of the injury and careful vaginal and rectal examination in the lithotomy and grade according to the recommended classifications. The rare buttonhole injury to the internal anal sphincter, it should be repaired transvaginally and with the vicryl 3 zeros. A layer tissue should be interposed between the rectum and the vagina by approximating the rectovaginal fascia to avoid the rectovaginal fistula. It's very important because there are the rectovaginal septum, right? There is a vagina, it's a rectum, and there is a septum in between. So you have to close the septum. What we are doing in a posterior repair, if you perform the posterior repair in cases of the rectocele and that, and there is a rectovaginal septum which we close it. So this is very important. If you will not do it, so there is a chance of formation of the fistula. So you need to do it. Sometime if it's higher up, you may need to put the omental pack in it. But most of the time, if it's a buttonhole and it's lower down, you just close it from the vagina, give a nick of the incisions and find out the size, and then just close that and close the upper one. Okay, in the 4th degree tear, torn epithelium repaired with the interrupted 3-0 sutures, 3-0, with the knots tied in the anal canal, anal lumen, right? So that it should not affect to the layer of the muscles. So whatever is there, it should be remained over there. So, and the other European countries, and it's very important, the catgut is withdrawn, they said. We are having the catgut with us in Pakistan, but it's not very commonly used nowadays. So what was the problem with the catgut? It was made up of the material which can dissolve by the process of the proteolysis. So in the proteolysis, there's more chance of having the infection. It catches the infection. So in a case for that, if you use the hydrolysis, which is the method of dissolving of the vicryl, it is far better and there's less chance of getting the infection. So the sphincter muscles repaired with a 3-0 PDS. PDS use किया है कभी किसी ने gynecologist में? It's a very good thread. Surgeons में ये बहुत commonly use होता है, but it's a very good thread and it has got a very good strength in it. So it should be used for the, it's a dyed blue color, which is nice suture. It should be used for the repair of the perineal tears, sphincter especially. So suture ends, they should be cut and short and it should be buried. It's very important. Sometimes what happens, the women comes to you with a pain, especially on one point, and they cannot sit. They say, Doctor Sahab, yahan dard hoti. And you just explore everything, you find, yaar, yahan to kuch bhi nahi hai, main kya bataun. And you just put your finger over there, yahan pain hai, yes, it's the painful. And you know why? Because if they had some sort of the repair, that was maybe the knot of that thing which is buried over there. And it is causing the pain for all her life. So there's a suture migration also does occur. So be careful when you apply the knot, that your knot may migrate inside and cause the pain, and it leads to the neurological problem, to the vulval problems. Now, the internal anal sphincter should be identified because its color is different. When you look at the color of the external anal sphincter, it is red, like meat, red meat. And when you look at the internal anal sphincter, it's a fish flesh, white meat, जिसे हम कहते हैं, it would be like that. तो उसको पहले तो recognize कर लें, that is far better, right? And then you start stitching that anal epithelium. उसकी जो knot है, it should be within the anal lumen. It should not go within the muscles. And then end-to-end anastomosis है इसका. एंड टू एंड आप करते चले जाएं. 1 सेंटीमीटर अपार्ट, 1 सेंटीमीटर उसका डिस्टेंस होना चाहिए, एंड देन यू जस्ट अप्लाई द स्टिचेस. टॉर्न एंड ऑफ द एक्सटर्नल एनल स्फिंक्टर अब ढूंढें. ठीक है, वंस यू क्लोज दिस थिंग, the whole anal canal and the sphincter, internal anal sphincter, you identified, you closed it, then you look for the anal canal, like external anal sphincter, and this is the head of the levator ani muscle. It retracts back, पीछे चला जाता है वो जो end. Then you have to find it out and grasp with the LSS forceps, and it is difficult in fact, but with the experience you will learn how to catch it. Then continue repair how the perineal muscles, they should be closed in layer to construct the perineal body to provide the support to the. Now what should be done? See, we will show you in a animal model, and I'll show you in pictures and videos as well. You catch hold of these anal sphincter heads, which is the levator ani head, which is retracted back. You identify and you just catch them, and then you start closing the rectovaginal septum over the anal canal, जो भी आप रिपेयर कर चुके हैं इंटरप्टेड. ठीक है, उसके ऊपर आपने उसको क्लोज किया. Then you will close the vaginal epithelium, and then you come down and you will find the perineal muscles. फिर इन मसल्स को आपने अप्रॉक्सीमेट करके क्लोज करना है, and then you will come out. So the rectovaginal skin approximation with the 3 vicals by the subcutaneous features से आप करेंगे. हम इसको भी मैं सबक्यू लगाती हूँ, so that is less painful rather than कि आप बड़ी बड़ी knots लगा दें तो पेशेंट के लिए बैठना भी मुश्किल हो जाता है. So rectovaginal examination, it should be performed to confirm the complete repair and ensure that no stitch has gone through the vaginal mucosa. ठीक है ना, यहाँ से अंदर क्रॉस कोई स्टिच नहीं होना चाहिए, अंदर का बाहर बाहर करना चाहिए. So detailed note and pictorial representation of the tears, it proves very useful when you review the patients. Of course the patient को आपको follow करना है, you have to follow up this. तो उसमें जब भी आएगी तो आपके पास अगर आपने तस्वीर बना के ड्रॉ करके रखा है तो you will remember, क्योंकि you have lot of the patients, एक ही मरीज तो नहीं है ना आपके पास, तो वो आपको याद आ जाएगा, अच्छा इसका ये टेयर था, यूँ रिपेयर हमने किया, and this was the thing. So follow up is very important for such patients. अब ये पिक्टोरियल है, इसमें आप देखें कि ये नीचे इसका एनल मिकोजा है, उसके ऊपर ये रेक्टोवेजाइनल सेप्टम है, और उसके ऊपर ये एनल कैनाल के ये मसल्स हैं. ठीक है जी, 3 में ये क्लोज होता है, उसके बाद वेजाइनल एपिथेलियम आ जाएगी. ये भी एक मेथड है, इसमें ये कर रहे हैं, ये अच्छा क्लियर पिक्चर नहीं है. दिस इज हाउ यू कैन क्लोज दी एनल किधर गया, एनल स्फिंक्टर. फिगर ऑफ 8 में आप क्या करते हैं, ये एंड टू एंड अप्रॉक्सीमेशन है. ये आप कर सकते हैं कब, व्हेन द पेशेंट इज़ एन एक्यूट इंजरी, उसी वक्त आपने एंड टू एंड एनास्टोमोसिस कर दी. ये देखिए एंड टू एंड एनास्टोमोसिस आपकी हुई है इसमें. ठीक है, रेक्टोवेजाइनल सेप्टम है, इसके नीचे है एनल कैनाल. देखिए ये एक पिक्चर है इसकी. अब ये एनल कैनाल का आपने वो पकड़ा हुआ है, और इसको आपने डबल ब्रेस्ट फॉर्म में करना है. नहीं सॉरी, ये एंड टू एंड है, एंड टू एंड एनास्टोमोसिस है एक्सटर्नल स्फिंक्टर की, यूजिंग दी मैट्रेस स्विचर्स. आपने मैट्रेस स्विचर लिया है, एक तरफ से आप लेके गए, सेकेंड साइड से फिर आप लेके आए. ठीक हो गया. अच्छा, अब आगे क्या करेंगे, पोस्ट ऑपरेटिवली इट्स वेरी इंपॉर्टेंट. वो आपको दिखाएंगे पिक्चर्स में, अभी मज़ीद वीडियोस भी चलनी है, यू विल हैव एन आइडिया. सो पोस्ट ऑपरेटिवली क्या करेंगे, द केयर फॉर द आइस इज़ वेरी इंपॉर्टेंट, बिकॉज गुड एंटीबायोटिक शुड बी गिवन. ये ना कहिए कि जी हमें तो किसी एंटीबायोटिक की ज़रूरत ही नहीं है, बिकॉज नंबर 1 दिस इज़ द एरिया विच इज़ नॉट ऑलवेज क्लीन. इट इज़ एसोसिएटेड विद द एनल inhabitant, who is that, जालिम E. coli. ठीक है ना. तो E. coli का काम क्या है, जब भी वो मिसप्लेस होता है कहीं ना कहीं पहुंच जाता है, तो अगर E. coli will disrupt that line of your switcher, तो वो जाके एब्सेस फॉर्म कर देगा, और वहीं से सारा आपका सारा रिपेयर का बेड़ा गर्क होगा. सो ऑलवेज कीप द थिंग्स दैट द पेशेंट शुड नॉट पास. शुरू में फास्टिंग करें, उसे 1-2 दिन तक उसी गट प्रिपेयर करो, और लेटर ऑन आप उसको 2 दिन एटलीस्ट रेस्ट दें, ताकि वो लिक्विड डाइट पे रहे. पेशेंट को भूखा मैं तो रखती हूँ, मैं कहती हूँ सॉरी फास्टिंग है आपकी 2-3 दिन की, सो दैट दैट एरिया शुड रिमेन नियरली क्लीन. देयर शुड बी नो स्टूल ओवर देयर. Then bladder catheterization, it should be done. It's very important because painful होगा, तो she will not pass the urine again. She will have the retention of the urine, and that is going to cause a problem later on. So good post-op analgesia so that she can do her activities. Dietary advice is very important. Along with that, you will give the stool softeners. Do not forget it. अगर stool pass करे तो फिर वो hard नहीं होना चाहिए. This is very, very important because we have the people who are not trained for the potty. This is very important. You know, if you ask the women, they have a lower abdominal pain, and you particularly ask whether they pass the stool daily, and it's normal, this is no, after 1 day or 2 days. So this is very important that you should know that daily, if she is passing the normal stool, she will not have the pain and heaviness and all that problem in the lower area. It's the flatus, it's the hard fecal matter which is causing the heaviness in the lower part of the abdomen. So lower abdomen is not only the genital tract, it is the rectal also, it is the bladder also. So we have to look after all of them. So bladder catheterization you did, you gave the good softeners and then asked the patient to follow up. Patient, when she is discharged home, so give her the good informations. Ideally, these women, they should be under care of some specialist team and who run the perineal clinic. This is what they started in way back in 2010 in their UK, England, and they were planning to start this perineal clinic. So the patient should follow them, like in which you have performed the AP repairs and this sort of the repairs, and they just look at them. So women should have given the complete information to ensure that they understand the implication of the sustaining OSS. What is it? ये problem क्या थी, कैसे हुई, और इसको कैसे आपने repair किया, and how she is going to handle herself later in life. And if there is a problem, then she should come back to you and should inform you. So where and when she need to seek the help, ये भी उसे पता होना चाहिए. ये नहीं कि वो आके पूरे डिपार्टमेंट में घूमती फिर रही है, कि उसे ये नहीं पता कि कौन बताएगा उसे. एंड द जूनियर पर्सन कैच होल्ड ऑफ द पेशेंट, क्या है बेबी यहाँ तो कुछ भी नहीं, अच्छा तुम अगली दफ़ा आ जाना. यू नो द बेबी हाउ शी विल बिकम द हेल्पलेस पर्सन, वो कहाँ जाएगी. सो गिव देम द पर्टिकुलर टाइम and the date and tell them this is the clinic where you should follow. इनसे मिलना है आपको. So this is very important that it should be, the information should be given to the patient very clearly. And it's far important if you give a written follow-up to the patient, okay, on this clinic and this place and this person you meet. So this is far better if you give. So following up, the discharged women should be advised to visit clinic weekly. And then if they are stable, 6 to 8 weekly. फिर उसके बाद आप 6 month पे बुला सकते हैं. Look for the signs of the infection in every visit. शुरू में तो आपको देखना ही पड़ेगा. Infection है, pulmonary discharge है, pain, swelling, rectal bleeding, or any episode of the incontinence of the fecal and the flatus, it should be reported. And if it's there, then you need to respond to that. Follow up to the perineal clinic. The women should be seen by the senior obstetrician 6 to 8 weeks पे. जूनियर को आके पहले भी दिखा दे, लेकिन 6 से 8 हफ्ते में उसका कंसल्टेंट विजिट लाजिम होना चाहिए for the assessment after the delivery, and they should be accompanied by their partners. Assessment made after the genital examination, scarring and residual granulation tissues and tenderness. अब 6 to 8 week पर ये सब कुछ हो चुका होता है ना, हीलिंग हो गई है, हीलिंग प्रोसेस के बाद उसकी कॉम्प्लिकेशंस भी हो सकती हैं. So she will tell you all that. So you have to look for all this stuff. All the women undergoing, they should have manometry and endosonography. This is to check the strength of the anal sphincter जो आपने बनाया था. अब वो जानना चाहते हैं कि how much effective it is. But if it is not there, you don't have the facilities of having the sonography or the manometry, your finger must be trained. So train your index finger for the squeeze pressure. If you know what is the pressure of a normal sphincter, you can differentiate it from the pressure of the abnormal sphincter. So you can take your decision on it. This is all clinical. So we must be trained in our clinical things first. So counseling and guidance is very important for the issues which is related to that. So management of the subsequent pregnancies में क्या करेंगे? अब वो patient कहेगी एक दफ़ा तो मुझे ये हो गया, अब next time मुझे क्या करना चाहिए? So after this, what should be done? The careful counseling. Elective cesarean section is advised and biased and inconsistent between the obstetrician and colorectal surgeon. We have a colorectal surgeon with us today, fortunately. तो ये एक study conduct की गई कि colorectal surgeons और obstetrician से पूछा गया कि आपको follow-up में what you suggest to your patient whether she should deliver vaginally or she should deliver abdominally. So they found that the 22% of the obstetricians, they said they should have a vaginal delivery. And 71% of the colorectal surgeons, 22% of the obstetrician and 71% of the colorectal surgeons were in the favor of elective cesarean sections. Means that you have 80% of the obstetricians wanted to have vaginal delivery. because they follow most of the time. So unfortunately, currently the data is limited. We can't say on it. So largely it is in the practice of the unit. So 2 risk factors identified in these patients which require the counseling with the couple. So you need to. But this is different in a different part of the world. अब मैं इसलिए agree नहीं करती. It's very important. You must tell. I tell you, Dr. Sahab, this is a very big debate and right. So risk of the oasis in a subsequent pregnancy. Now we are going to think on to the subsequent pregnancy what they are going to. So risk of recurrence क्या है कि अगर एक दफ़ा आपका tear हो चुका है तो फिर अगले 5-fold there is more chance of having that. But 95% of these women, they do not sustain the recurrence. चांस ज़रूर है लेकिन हर एक को हो नहीं जाता. सो रिस्क इज डिपेंडेंट अपॉन द टाइप ऑफ एपिजोटमी, मोस्टली मिड लाइन, इंस्ट्रूमेंटल डिलीवरी और विदाउट एपिजोटमी एसवीटी. तो ये सारे हैं जो कि लीड करेंगे फॉर अगेन हैविंग द सेम काइंड ऑफ द प्रॉब्लम. सो दे फाउंड दे डिड अ स्टडी ऑन टू द primary women. So 4,000 around 15 patients, and they had a first delivery and they studied, and they found that 19% the risk of the recurrence in these women was who had this problem, and they found that there was 2.1% they were having this problem because of without episiotomy. आपने episiotomy नहीं लगाई, so they had it. So 11% with the midline episiotomy and 21% with the midline and with the instrumental deliveries. So this is always associated with some of the risk factors. So what is the risk of the anal incontinence after another vaginal delivery? आपने कर ली vaginal delivery, अब पहले तो continent थे. So this is again a study on to the 43 women who had the previous delivery with the oasis, and the rate of the incontinence was 56% as compared to 34% who did not had such history. A study by Singley and that the risk of the anal incontinence after some 13 years of the oasis repaired was significantly higher. And as I said earlier, this is because of the aging process they had it. So what is the recommended practice? If no facility of anal manometry, endosonography and the clinical evaluation, it should be done. मैंने कहा अभी आपकी finger, it must be trained. So asymptomatic women with a good anal tone and the vaginal delivery, it should be allowed to deliver. So all those symptomatic women should refer to the center with the facilities with the anorectal assessment, and it should be advised the cesarean section. These are the problems they can occur later on after the different kind. This is here there is no perineal body. See, some more chance that this is the simple line where the anal continence is there. So in conclusion, I can say the deficiency in the training of the doctors and the midwife in the perineal anatomy, ability to recognize the sphincter injuries is not optimal. So they are suboptimal. So extensive training and education in this area is required. A need for the hands-on workshops in teaching institutes, an obstetrician role in reducing the postnatal health problem is pertinent. And then there is a need for the training of the specialized nurses, midwives who can give better patient care, information and guidance, and they can act as a counselor and work as a team of the Urogyne Center. Thank you very much. This is me with the Obama. Thank you. Now,
How did you go with the Obama? Is it a picture or you?
it's me. Obama खड़े हैं, देखें ना आप. right? Yeah, this was the Madam the South. Yeah. This was Madam South. Okay, thank you very much. We have the next session of the videos. So
Before you finish, I just want to make a comment.
yeah.
I have seen late university professors at the age of 68.
Ji, ji.
She came to my clinic. She was a sister of one of the anesthetists.
Haha.
And she said, I have miserable life.
हम्म।
I cannot move around because I have no control on.
अब इसमें ये नहीं पता कौन सी है,
And it's spoiling my
ये देख लेते हैं ये कौन सी है।
So I examined this lady in the clinic. I did examination. She was an old age, and there was no gross incontinence. So I said, you do a pelvic exercise, which you can do. You're 70 years old, and take Imodium
ये
capsule.
वाला चला, इसको पॉज कर दें। हाँ।
And I said, take one Imodium first, and if you're not happening, take two in a day. Then you may go into two in a two in the for 3 times a day. From that time till today, it's about 2 years now. And she was working in my relative university as a professor. And on that day, my relative phoned me and said, the professor is sitting me in front of me, and she is praising you in every prayer that you made the life from miserable to a remarkable life of single Imodium capsule. So Imodium is a slowing agent. If you give that slowing agent in the colon, it slows the movement of the colon. And therefore the problem of transient and the stool get bit harder, so that the problem of incontinence in harder stool is less. So I would suggest that if you have got anal sphincter, which is there, it's contracting, what is the age it is there, the first line of treatment is that you should not have too much bulking agent. You should have less water, so the things will get drier, as well as add Imodium, which is the drug which slow this, and you can have a reasonable control of incontinence for liquid. No control for flatus, but reasonable control for liquid feces. And I would suggest that one of the gastroenterologists in St. Mark Hospital said to me, if I want to go by boat from here to Australia, the medicine I will carry in my pocket is the Imodium. He says that you don't want to do too much problems of this ablution. And this. Yeah. So my concern is that you should have this in your practice also. It's a very simple drug. It produces some bloatness, but if it works miraculously with the people. Yeah. Thank you very much, madam. It was very nice. It's the first time in my life that I am being sitting with the gynecologist. This is first time in my life. So it's about 35 years. First time I have been exposed to the gynecologist with the eminent gynecologist like madam and like you. And I'm very glad that madam is from Dominical College, from where I was also a student at the time when madam joined as an assistant professor. So she has a stature. And your people are very lucky that you have got such a stature woman teaching you the basic anatomy, and the madam Shagufta is teaching you the basic management of this. So I must congratulate all of you, and trying to do that. One thing in surgery, there is no second day. Surgery, if something happened, break your sleep. Break your sleep, come and do the job properly. That is the message which I want to give to all. Yeah. This is because for patients is that is your booking. You booking for the delivery, and if something goes wrong, you can't sleep. You can't sleep. You have to come. This is your 1 hour, 2 hour, but that is detrimental for the patient. So I think that people should be prepared that if you are doing a delivery in the middle of the night, then senior must make sure they're available, the pediatrician makes sure be available, so that the safety profile should be there. Otherwise, this society is very, very violent society nowadays, with electronic media and everything, and the FIR is being registered against people for no reason. Whether people brought dead there in a hospital. The first thing is that, yes, first thing is that get an FIR to their doctor, and then you are looking for a bail, and the electronic media, and at the end of the day, they thresh out the 2 lakh rupees, 3 lakh rupees from your pocket to get this case where you have no play at all.
Yeah.
So be safe.
So doctors are
Yeah.
the people who are alone.
Yeah. So you
They
should
walk
be,
straight
yeah,
in
you
the
should
road.
be safe. And I don't mind calling my senior in the night if I'm in trouble, because that is the,
Doctors are alone.
yeah.
They walk straight on the road
Yeah.
where there is no U-turn
Yeah.
and where there is no support.
So you see, I've been in this medical legal business, and I used to go alone. My hospitals say we don't have a lawyer, we don't have a travel. You have to go yourself, and then you have to face the music yourself. I said, I'm working for a bloody hospital. It's not my private practice. And if the professors and the associate professors is not going with me as a senior edge, I am going to see that things. This is not on. And then
With the
everybody says,
passage of
you are the consultant, junior, senior registrar, the consultant. No. Senior registrar is working under the umbrella of the professor for the professor.
Yes, yes. Sir, unfortunately, now this thing is going more worse because they are destroying this unit system where the people learn under the umbrella of the seniors and the seniors take care of them. Now this is happening in most of the places, and especially in the private setup में तो होता ही है, लेकिन government में भी even then. So they do not want the seniors to be involved in it, and they catch every doctor. You know, and I always tell them everybody has got a different experience level. So you cannot measure her experience with mine. I'm older than her. Of course, I have more age, more learning experience. So which one? So why you want to give the blame to the younger doctor? Huh? Unfortunately. So the doctors, I want to give this message from this platform to all of my colleagues who are sitting at home, and they are the seniors as well, that the doctors should back and they should give the space to their own colleague. If they have some problem, they just individually discuss with them. And please do not make it an issue and create a problem. And this is not something like going to help you. Of course, आपने उसकी तरफ जो एक finger point की है, तो 4 आपकी तरफ finger point हो रही हैं. तो अपने junior को अपना साथी ही समझें.
Practice.
So
you
this
see,
is very important.
Yeah, now if you look into yourself and myself and all madam is
Complications
here,
can occur to anyone.
When you operate, when you see patient,
हाँ.
you will complicate. But if you don't see patient, you don't operate, there is no complication.
There is no complication.
And
तो
you say,
किसकी
मेरे साथ तो आज
complication?
तक हुआ ही नहीं because you
जो
never
काम
operate, you never
करेगा,
delivered.
जो काम करेगा, जो घोड़े पे सवार होगा, वही तो गिरेगा. वही गिरेगा ना. जिसने कभी सवारी करके देखी नहीं, उसने क्या गिरना?
But
So
believe
गिरते हैं
me,
शाह सवार मैदाने जानिए.
believe me, if you are well
ठीक है ना?
trained, if you are well
It's
trained,
better.
cautious, 99% everything will be all right.
Okay.
Don't
Thank you very
panic on
much,
that.
sir.
Thank you very much,
Thank you very much. Thanks for coming to us. It's a nice pleasure to have you.
I enjoyed myself because I learned
Yes, we learned a lot from you. Thank you. Thank you very much. Thank you. We are going to continue our workshop, the next part of it, which is the video session, right? In this, unfortunately, there is no voice behind this video, but I like it very much and I found from the net. So I included this video particularly in my workshop. So this is the red, it is the anal canal. ठीक है जी, रेड पार्ट जो एनल कैनाल है और इसमें ये रेक्टोवेजाइनल सेप्टम, एंड दिस इज व्हाट इट इज, जो ऊपर रेड वाला है, दिस इज द स्ट्राइटेड मसल्स ऑफ द एनल स्फिंक्टर. So he is showing you that if you have a tear like this, ठीक है, तो find out the apex, कहाँ है एनल कैनाल की. एपेक्स को आपने सर्च आउट करना है और फिर उसके बाद दे सेपरेटेड, यानी आपको उसका देखिए ये डिसेक्शन हो रहा है. So they dissect out the anal canal from the rectovaginal septum, and from the rectovaginal septum the upper part. इनको सेपरेट करें. Only then you can stitch the rectal mucosa with the interrupted sutures 3-0 and the knot is tied within the 11. वो आप कर सकते हैं. तो अभी ये आपको क्या बता रहे हैं? That is the separation. ये मेरा हाथ तो नहीं आ रहा, नहीं. He is going to separate it. ये प्लास्टिक मॉडल बना हुआ है इनका. ये इन्होंने मैं आ रही हूँ. Yes. Initially they did the dissection. They dissected out the rectal mucosa from the rectovaginal septum. Now they found the apex and they started making the loop and the knot will be tied with the 1 centimeter apart and 1 centimeter distance from the each stitch. इंटरनल एनल स्फिंक्टर इसके आगे है. जैसे आपने ये रिपेयर किया, देन यू कैन फाइंड अ थिकनिंग इन द large ball, and that is the condensation of the smooth muscles of the gut, and those are basically the longitudinal line of the smooth muscles of the gut which are thickened at that part, and it is giving the responsibility of continence. So it's not something which is different. It's the same longitudinal cord of the smooth muscles which is thickened. So that is the internal anal sphincter. So they repair the internal anal sphincter with the another method of like this. See, yeah. These are mattress switches he applied at the internal anal sphincter, which is the condensation of the smooth muscles, longitudinal cord of the smooth muscles of the gut. and that act as a internal anal sphincter. So what he is doing? Yes, is again taking that. See, they have taken the 3 switches mattress और end तक को उसको stitch कर रहे हैं. So this is going to close the whole of the gut. See, if you leave this part, it is again going to cause the incontinence. अगर ये छूट गया, so you have to come really at the edge of the anal canal. नीचे तक आना है. end-to-end repair. ये method है which is being depicted here, and it shows you how the end-to-end stitch should be taken. ये फॉर्म पे आपको लेके बता रहे हैं कि किस तरह से आपने end-to-end रिपेयर करना है. It's approximated nicely. Now, this is another method of closing the anal sphincter, external anal sphincter, which is the overlapping method, double breast. And how it should be done? The 2 heads of the levator and eye muscles, they are taken from both of the sides with Alice's forceps, and you have dissected out, and you have taken out enough good chunk of the muscle, and then you will bring in the midline and close it in a double breast method. So this is what it is doing. के बाद फिर आपको विजाइनल म्यूकोजा बिल्कुल उसी तरह से क्लोज करना है जैसे कि एपिजॉटमी में करते हैं, और फिर देन अगेन यू विल गो डाउन लाइक एपिजॉटमी, मिड लाइन एपिजॉटमी की तरह स्किन बंद करते हुए चले आएंगे. ओके अब ये जो लेफ्ट बिहाइंड है ना, ये वाला पॉइंट हम इसे क्लोज करते होते हैं, सर्जन इसको खोल छोड़ देते हैं। फारिया बैठी हैं, दे लीव दिस, वी क्लोज इट, ऑल ऑफ इट, हम लोग क्लोज करते हैं क्योंकि हमने स्किन बंद कर देते हैं। वी क्लोज ऑल द स्किन। हमें आदत पड़ी हुई है ना गायनेकोलॉजिस्ट को, तो हम एपिजोटमी क्लोज करते हैं ना पूरी, तो वी क्लोज इट विद द स्किन, बट सर्जन्स दे लीव इट, वो उसको खुला छोड़ देते हैं। बहुत लंबा टाइम लगता है और वो पेनफुल बहुत होता है, इन्फेक्शन, पेन, उसमें सब बहुत होता है। इसमें नहीं होता है, डिस्चार्ज होता है। और ज़ाहिर है फीकल मैटर है वहाँ पे। अल्लाह वला कुव्वत इल्ला बिल्लाह। अल्लाह वला कुव्वत। ये बता रहे हैं कि आपको इसमें डबल ब्रेस्ट मेथड से यू हैव क्लोज इट। अब ये विजाइनल म्यूकोजा बंद करेंगे, उसके बाद दे विल क्लोज इट आउट। ठीक है, अब ओवरलैप कैसे किया वो अब आपको अलग से बताते हैं कि उसका स्विचर की टेक्निक बड़ी अहम है। इसको लाने का इस वीडियो को मेरा पर्पज़ ये स्टिच था कि ये हम देखें कि हाउ दे मेक इट, है ना। इट्स वेरी इजी एंड इट्स वेरी इंपॉर्टेंट। मुश्किल नहीं है, लेकिन इसका एक मेथड है, सीखने की ज़रूरत है। सो इसे यहाँ से पास किए एंड ऊपर से लेके आ रहा है। आप देखिए धागा ऊपर से आया, नीचे चला गया। ठीक, अब ये वापस आएंगे। ठीक हो गया। दिस इज द सेकेंड स्टेज इज गोइंग टू टेक। ऊपर से नीचे जाए, ये बाहर की। मुझे अच्छा लगा इसका मेथड ऑफ टीचिंग कि हम नीचे से लेकर आते हैं ना ऊपर, इससे ऊपर से नीचे गया है। हाँ जी, ये हम नीचे से लाते हैं ना, अगर नीचे चलेगा तो नीचे से लेकर ऊपर से नीचे। अब ये देखें यहाँ से अब फिर वहाँ जा रहे हैं। इसका मतलब ये है कि सी अब दो, हाँ हाँ जी, और इट्स वेरी इंपॉर्टेंट। दिस विल गो अंडर दैट वाला पोर्शन। ये देखें, यस, दिस इज हाउ इट इज। सो स्वीट, वेरी नाइस मेथड। अच्छा, बड़ा अच्छा समझ में आने वाला कि आपने यहाँ से निडल पास किया, ऊपर से लेके नीचे गए, इधर से आए, फिर यूँ फिर नीचे चले गए। थैंक यू। अगली वाली वीडियो स्टार्ट करते हैं। यही है मेरे में, यही है। हाँ हाँ, वीडियो है बेटा। डॉक्टर पुष्पा श्रीचंद, शी परफॉर्म्ड वन ऑफ द रिपेयर ऑन अ पेशेंट। तो मैडम, बट वी हैव टू, मैडम के एक रिपेयर थी। हाँ, शुरू से लगाएंगे ना, इसे याद हुई है ना, ये तो यहाँ से। हाँ, पीछे ले जाए। यस, आप स्टार्ट करते हैं। जी, अजान ये 1:30 बजे तक है, 1:30 बजे तक चलेंगे अजान।
in which we will repair on animal model.
नहीं ये नहीं, दूसरी वाली, ये हम एनिमल मॉडल फिर समझेंगे। मैडम पुष्पा की हैं जो ना, आइए उनको। मोहम्मद
patient who is 20 years young age and she has developed 4 degree variation
इसको शुरू
after
से
her
करें,
first childbirth.
इसको शुरू से नहीं
We
है।
have
हाँ This is a courtesy from Professor Pushpa Sirijan. She is the president of Pakistan Urogynae Association, and I took this clip from Madam. So it's going to help you. सिनेरियो है, इसको ये देखें, जैसे उसने डिसेक्शन किया था, क्या याद है कि ये सेपरेटेड द विजाइनल epithelium mucosa from the rectovaginal septum and then anal canal. अब ये एक पेशेंट है जिसका chronic sphincter है which is torn, right? तो उसको जब आप लेते हैं तो there is a scarred area, ठीक है ना, ये एकदम खुला हुआ है सारा कुछ। तो what you will do, you will find out the apex and then you will remove this scar part and then you have to make the very good dissection so that you will separate the epithelium of the vagina from the rectovaginal septum and from the anal canal, the anal epithelium, anal mucosa, right? So this is a very fine dissection. It is being made over here and it requires expertise and recognition of the 3 layers as you saw in the previous one. And हाँ जी, ये एनल कैनाल खुली और आखिर में इसका वो एनल स्फिंक्टर भी टॉर्न है।
vaginal wall has been separated from underlying anorectal mucosa for a distance of about 3 to 4 centimeters. And now we will expose the external anal sphincter. This is the rounded muscle of external anal sphincter. We will mobilize the external anal sphincter to have tension-free closure. These white longitudinal fibers are of internal sphincter and these rounded circular fibers are of external anal sphincter. We excise the fibers edge of anal mucosa so that we get a healthier tissue for approximation. We approximate the anal mucosa and the first stitch is taken about ½ centimeter above the apex. anal mucosa has been approximated by interrupted sutures, and now we approximate the internal sphincter fibers, and these are the longitudinal fibers of internal sphincter. The fibers of internal anal sphincter, they have been approximated by placing 3-4 interrupted sutures. These two Ellis tissue faucets, they have been applied to the cut edges of external anal sphincter. Good mobility is achieved to have a tension-free approximation of external anal sphincter. We are approximating external anal sphincter by 2 interrupted sutures, and this is end-to-end anastomosis. External anal sphincter has been approximated by placing 2 interrupted sutures. Now we are approximating the vaginal wall by applying interrupted sutures. The vaginal wall has been approximated. Now we are approximating the perineal muscles with interrupted suture. Perineal muscles have been approximated, and now we are going to approximate the perineal skin with help of interrupted 2-0 suture. Now the 4-degree perineal repair has been completed. You can see a normal enteritis, normal perineum of about 3 to 4 centimeters, and normal anal orifice.
In which we will repair on animal model. This is a goat pelvis, right? In this pelvis, definitely the anatomy from the female, human female, is different. But what we are trying to do is that we want that the tissues, they may mimic, and we can differentiate the different layers. Rather than we can do it on the other models which are not animal, like inanimate. It's better than that. On animal model, you have to find out this is the birth canal and this is the rectum. Can you see? I will inflict an injury on it as 4-degree perineal tear. I'll make it a tear, right? Then I will repair it. So if you make a tear, you want to make the mediolateral episiotomy. So this is the middle part, right? And we can suppose that this is a perineal body, and for the mediolateral episiotomy you need to give a midline cut and then you go laterally, right? And for the 60 degrees you say, then 60 degree may you are not in the midline, you are on the right side of the midline, and here you give the mediolateral episiotomy. So there's a less chance of having the 4-degree perineal tear with that sort of the episiotomy. If somebody has a 4-degree tear, most likely that episiotomy which can be causing the problem is midline. So I am making it 4th-degree perineal tear, right? I am inflicting the injury and I made it a 4-degree perineal tear. Now you can identify that this is the urethra, this is vagina inside, and this is the rectum. Okay? You got my point? Now I'll find it out with the artery forceps. I'll show you. This is the apex artery. इसको पकड़िए. One more artery. These are the two edges. This is the apex and this is the midline tear in rectum. Fine. Now in this case you need to identify first. How you are going to identify? Give me a forceps. This is the rectal mucosa which is cut. Okay, it's not a very big tear anyway, but we have to close it. चलिए मैं थोड़ा इसको और बड़ा करती हूँ. Hold it, please hold it. हाँ जी. Yes. ये rectal mucosa में tear है. ठीक है जी. और ये vagina में tear है. और इसमें this is the rectovaginal septum, fascia over it. Okay? Hold it with artery, please. Yes. So this is the tear in the rectum and one more artery. इसको please आप क्यों करें? हाँ, thank you. You can well see in it that this is the end of the striated muscles of external anal sphincter. ठीक है जी. अब यहाँ आपको आइडेंटिफाई हो रहे हैं. मुझे आर्टरी एक और दें. रखें आर्टरियाँ बहुत सारी. हाँ, एलिसेस दें. You hold with the एलिसेस to the skin fold. एलिसेस एक और दें. You need to identify the striated muscles. उसके बाद आप उसको रिपेयर करते हैं. Good. This is the head of the anal sphincter जो मैंने अभी काटा है. ठीक है. एक और दे. एलिसेस. एलिसेस. थैंक यू. प्लीज इसको होल्ड कीजिए. दिस इज एलिस. दिस इज द एक्सटर्नल एनल स्फिंक्टर. ठीक है जी. हाँ, आप पकड़ के रखेंगे, नजर आएगा. So this is the vagina, right? This is the vaginal epithelium. This is the rectovaginal fascia. These are the two muscles of the external anal sphincter. These are the two heads. We are going to approximate it and we'll make it the same, restore the anatomy which I destroyed it. Give me the 30 PDL. Vical. ये भी vical है कवच में, yes. लेकिन this is straight needle, नहीं, curved needle चाहिए, curved needle. अच्छा, now you identify where is the rectal injury, rectal mucosa, right? उसको भी आपने find out करना है, rectal mucosa में rectal injury कहाँ है, ये है. This is the rectum, sorry. ठीक है. Now first of all we will repair this rectal mucosa and then we will go up. We have identified the two heads of the external anal sphincter and this is the internal anal sphincter, right? I'll show you. Where is the internal? This is the internal anal sphincter. It is the condensation. अगर आप इसको ज़रा गौर से देखें, इसको होल्ड कीजिए प्लीज़. I'll show you. Sorry, artery. तो ये इसका नहीं, इसको आप नीचे लेके आए. दिस इज दी एक्सटर्नल एनल स्फिंक्टर का ये हेड है, ठीक है, ये वाला ये एनल स्फिंक्टर है, ठीक है जी. इसको आइडेंटिफाई करना ज़रूरी है, समटाइम्स इतने आराम से नहीं होता, लेकिन आपने इसको जो रिपेयर करना है, इन दैट रिपेयर यू विल टेक ऑल ऑफ देम. नाउ डेज इट इज़ रिकमेंडेड दैट यू कैन स्ट्रेच इट. No knots in the lumen. Why? निकालने. Because the knots become nidus for the infection. So if you want that the wound should remain clean cut, so there should be no knot. You can cut.
दोनों?
नहीं, एक काटेंगे आप.
अच्छा, वो interrupted नहीं?
Continuous stitches लेंगे. बल्कि इसको पकड़ लेते तो बेहतर ही था. ये मेरे हाथ में बार बार आ रही है. It's not a good. खैर नहीं, ये काम नहीं करें. इट्स नॉट गुड. ठीक है जी, आप इसको यूँ होल्ड करेंगे. वी कैन रिपेयर इट कंटिन्यूस स्विचर एज वेल. आप इसको काट भी सकते हैं, लेकिन अभी रिसेंट रिकमेंडेशंस ये भी हैं कि आप इसको कंटिन्यूसली रिपेयर कर सकते हैं. असिस्टेंट क्लासेस नीचे कर उतार दो. कान से उतारो, उतारो साइड से. ये इसमें उतार दो. हाँ, ऐसे बस ऐसे. हाँ जी, ऐसे. थैंक यू. वापस करना है इसको. किसको? इसको कान को. ग्लव चेंज करो, ग्लव चेंज करो. मैंने इसको नहीं टच किया. ठीक है. सो यू विल आइदर आप इसको यूँ पकड़ के रखेंगे. मैंने अभी इसका वो काट दिया है थ्रेड, तो इसलिए थोड़ी प्रॉब्लम हो रही है. ठीक है. होल्ड दिस प्लीज. उसको छोड़ दीजिए. जस्ट लीव इट. हाँ, बस थ्रेड को फॉलो करें. You just follow the thread. No need for you. So इसको आप इंटरप्टेड भी कर सकते हैं, जो हमारा पहले का तरीका था, और इसको आप कंटिन्यूसली स्विचर भी कर सकते हैं. 1 सेंटीमीटर अपार्ट, 1 सेंटीमीटर अवे फ्रॉम द स्विचर लाइन. 1 सेंटीमीटर अपार्ट, यानी एक स्टिच और दूसरे स्टिच में 1 सेंटीमीटर का फासला होना चाहिए, उससे ज़्यादा नहीं. ठीक है. होल्ड करें. होल्ड द स्टिच. Surgical methods, according to the research, they get changed. most of the time, so we must follow the recent trend and get equipped, coincide with them कि how we can manage it. ठीक है, पकड़ते जाएं. ये इसको छोड़ दीजिए. Elasticity. अब यहाँ एक बड़ी अहम बात है कि ये इंटरनल एनल स्फिंक्टर है जिसको हम स्टिच करते हैं. हाँ, एनल म्यूकोजा, condensation of anal mucosa at one point, it is the internal anal sphincter. So if you identify well, if you don't, even then you can stitch it in a proper way, so this is going to help. But you have to stitch all around. ये मैंने अपने उससे सीखा कि आप उसको complete stitch करें. जितना complete आप stitch करेंगे उतना ही later on wound healing बेहतर होती है. ये आ गया. अब इसको हम यहाँ पे छोड़ भी सकते हैं. हाँ, पकड़ लें. You have to keep it like this.
तो इसका मतलब है कि
खींचना नहीं.
मुकोसा की कंटिन्यूएशन में ही उसको ले सकते हैं.
हाँ
It is
जी.
not identified.
हाँ, बिल्कुल उसको लेंगे आप.
If it is identified, then you can finish the mucosa.
ये मैडम internal anal sphincter and anal mucosa, it is closed. No. Unfortunately, it's a अजीब सी बात. Now, coming to the external anal sphincter, two heads. इनको हम आइडेंटिफाई कर चुके हैं. तो अगर आइडेंटिफाई नहीं किए हैं तो then you will go and find out in this area because they get retract back. See, this is right. तो इसमें आपने एक स्टिच लिया. एक मिनट, फॉरसेप्स, सॉरी. ये इसको भी मैं सही तरीके से प्लेस करूं ताकि ये मुझे सही नज़र आ जाए. हाँ, ना हाथ उससे पकड़ें. हाँ, उससे पकड़ें. इधर से पकड़ें, इससे पकड़ें. हाँ, आपको नज़र आ जाएगा. ये है एक्सटर्नल एनल स्फिंक्टर का हेड. सो it get retract back. Yes, I identified and I caught it. अब मैं क्या करूँगी? अब मैं इसको स्टिच लगाऊंगी और ये होल्ड कर लूँगी. This is end-to-end anastomosis. The two ends of the external anal sphincter, they are caught and then they are stitched together. So I took one stitch from one end and then I'll go in the other one. No, simple end-to-end है.
End-to-end or overlap, but end-to-end in acute cases, end-to-end helps.
नहीं, इसको सिर्फ पकड़ना है. इसमें से आपने डाल के, बिकॉज अभी आपने ऊपर से रेक्टोवेजाइनल फेशिया भी क्लोज नहीं किया है, तो इसको आर्टरी लगाएं. नहीं, टिप पे लगाएं. हाँ, अभी मैंने सिर्फ लिया है. इसको आप काटें सीजर. Usually I take 3 stitches to secure the external anal sphincter. In a case of the women, this is a fleshy head, and then you need to secure it so that the complete fibers of the external anal sphincter must be closed and it should not be retracted back, and you may not miss half of it. If you mix half of it, then the chances are that the repair, it may be complete if you can see, but there may be the symptoms later on. So if you want to have a good results, so better is that the whole fleshy part of the sphincter, it should be in the stretch and it must be closed. लाइए आर्टरी, एक आर्टरी दें, हाथ में दे दें, छोड़ दें, कट कट, ये इसको ले लें, नेक्स्ट दे देंगे, ठीक है जी। इसमें मैंने 2 लगा के मैंने इसको आइडेंटिफाई किया। देन आई विल गो अप anal mucosa and then there is a rectovaginal septum. Then you have to close the rectovaginal septum. If you will not close it, and then you will have the rectocele cystocele, rectocele especially. ठीक है, this septum is very important. फिर उसके बाद मसल्स आते हैं, फिर आपके पास पेरिनियल मसल्स आएंगे। तो इसके लिए आपने एक तरीका है, आप आइदर यू डू लाइक दैट, very important part of this repair, that you should identify the rectovaginal septum and repair it. इसको भी आप पकड़ लेंगे, हाँ जी। इसको कंटिन्यूस पे ले सकते हैं आप, हाँ ये मेरे लिए थोड़ी सी सपोर्ट हो जाएगी। लेकिन इसमें आप कर क्या रहे हैं कि बेसिकली यू आर रिपेयरिंग दी रेक्टोविजाइनल सेप्टम। ये सेप्टम आप ले रहे हैं बिकॉज ये आपका आगे एनल स्फिंक्टर है, तो ये आपका सेप्टम है। ये देखिए ये खासा प्रोमिनेंट है,
इसके साथ साथ ना मैडम,
कैन यू सी, नज़र आ रहा है सेप्टम, दिस इज़ द सेप्टम। ये बहुत प्रोमिनेंट है इन केस। तो आपने पहले एनल म्यूकोजा क्लोज किया, उसके बाद आपने रेक्टोवेजाइनल सेप्टम पकड़ा और उसको आपने इस तरीके से आइडेंटिफाई करके उसमें स्टिचेस लिए। अब ये आपने इसको भी संभाल लेना है। एक आर्टरी लगाइए प्लीज़। अच्छा छोड़ दें, एक आर्टरी वहाँ पे भी है। अभी हम इनको अभी हम टाई करेंगे तो उस वक्त हम सारी आर्टरीज फ्री कर लेंगे, ठीक है ना। आप इसको पकड़ेंगी, द लास्ट स्ट्रेच यू विल होल्ड फॉर मी, सॉरी, थैंक यू। सो इस स्ट्रेच में मैं क्या करने वाली हूँ, द पार्ट विच इज़ लेफ्ट बिटवीन द एक्सटर्नल एनल स्फिंक्टर एंड द रेक्टोवेजाइनल सेप्टम, इसको मैं पकड़ रही हूँ। ये देखिए इसको मैंने ट्रांसवर्सली लिया है सो दैट आई शुड टेक द मोस्ट ऑफ द पार्ट ऑफ इट, है ना। ये मैंने इस तरह से लिया है, ठीक है। और इसको मैं यहाँ से दोबारा निकालूंगी दूसरी तरफ को। देखिए ये आपका सेप्टम था और ये आपका एनल स्फिंक्टर है और मैंने इसके बराबर से इसको यूँ ले लिया, ठीक है जी। सो आई टुक दिस दैट, ठीक है। नाउ व्हाट आई विल डू कि मैं इन सबको लाइन से क्लोज करूँगी। ओके, आई विल क्लोज, ओके, यस डू इट। तुमने एक पार्ट छोड़ा था ना?
नहीं छोड़ा।
ओके, क्लोज इट, राइट, ठीक है जी। ये हमारा आखिरी स्टिच है, ये हमारा स्फिंक्टर है, ठीक है, ठीक है। अब हम इसको क्लोज करना शुरू करेंगे। वी कैन कम फ्रॉम अबव डाउन, ऊपर से हम नीचे आते हैं, तमाम स्टिचेस को क्लोज करेंगे। Yes. Okay. This is the second stitch. in the rectovaginal septum. This is I'm closing. This part is very important because this can lead later on in the life as a rectocele. So you need to repair the rectal fascial, rectovaginal septum. This is the third stitch. Near to the knot. Then I will repair this part of the external anal sphincter. ये है.
Why these are tied in the end?
Because it's easier. This is sort of the easier thing you can do, and you may not be able to take the proper stitch if you tie the earliest one. So space may be reduced. Yeah, वो reduce हो सकता है. You may not get the proper things. So for the repair of this part, you have to make them to clear to close to each other. You know, only then you can. Yes. See. So this is what we did. What we did, we have repaired the rectovaginal septum and external anal sphincter as well, and now I am going to close the vaginal part, and above that there is a superficial muscles of the vaginal skin. Below that you can have one layer. That मुझे दीजिए आप approximate उसको continuous लेंगे. These are 3 layers, very important. अगर आपने कोई एक लेयर भी मिस किए हैं, so आप इसको rectovaginal septum को आपने cover up करना है with the muscles. उसके ऊपर between the mucosa vaginal epithelium and the rectal epithelium and the rectovaginal septum you should put the interposing muscles.
3 0 ही है या फिर 0 दूँ?
यही सही है. Forceps. Okay. No, it's all right. So, थोड़ा this is the vagina. No, I'm taking the muscles below the vaginal skin and I'm closing them with a continuous layer below the vaginal skin. ये आपकी इसको आप एपिजोटमी की तरह स्टिच करेंगे. ये छोटा क्यों है? नहीं 30 नहीं खोलो ना.
बस 0 ही है, इसीलिए मैं पूछ रही हूँ. 0 ही है, कोई बात नहीं.
हाँ दे दो. Any question up till now? सही है.
It will be more clear when you will go outside and the facilitator will be doing it and you will be practicing it in front of them side by side. Then it will be more beneficial for you.
I think in a video, is it clear? Is it clear in the video? I think this is the better way of doing it. Reason being, this is the animal model which has got more of the resemblance with that the human layers, vaginal and rectovaginal septum. Rectovaginal fistula. You can learn better. So I have given you all the description of the layers so that you can identify them. ये हो गया जी मैडम. जस्ट बिलो मसल्स में आप उसे पकड़ेंगे, फॉलो करना है, फॉलो द थ्रेड. इसको कंटिन्यूसली रिपेयर कर रहे हैं. हाँ जी, विजाइनल मसल्स, ताकि उसको आपने रेक्टोवाजाइनल सेप्टम को कवर करें. ये सुपरफिशियल पेरिनियल मसल, डीप पेरिनियल मसल्स हैं जिनको मैं रिपेयर कर रही हूँ. पकड़ते जाएं. या ये एक फ़र्क है कि ह्यूमन से ये डिफरेंस है कि मसल्स बहुत पतले हैं, लेकिन लेयर्स समझ में आ जाती हैं इससे. और ये कि आपने इसको कंप्लीट रिपेयर करना है. एक डिफरेंस है गायनाकोलॉजिस्ट एंड सर्जन्स, कोलोरेक्टल सर्जन्स रिपेयर, वो बड़ा अहम है जो मैं यहाँ एक्सप्लेन कर दूँ कि जो सर्जन्स हैं दे प्रेफर टू लीव द लोअर पार्ट अनक्लोज्ड. दे वांट कि इसे आप सेकेंडरी हीलिंग पे स्टिच छोड़ दें. सर्जन्स दे वांट टू लीव दिस पार्ट. रेक्टम के पास जो है वो कहते हैं कि मैं आप सेकेंडरी इंटेंशन से जो हीलिंग है उसके लिए छोड़ दें. बट माई ओपिनियन एंड द अदर गायनाकोलॉजिस्ट they are performing, they have the opinion that if they close it completely, this is the better option and the patient get earlier out of the bed, mobilized, and she has no complication. Yes, reason being that we know it, the birth canal, it is very much near to the rectum and it get infected by the E. coli. Reason being ke they have the mess blood which is going on and all that stuff, तो ड्राई नहीं रहेगा. बट सर्जन्स दे हैव देयर ओन ओपिनियन. उस पर हम इख्तलाफ यही है हमारा उनसे कि हम इसको क्लोज़ करते हैं, वो इसको डेड स्पेस को क्लोज़ नहीं करते. ये काट दिया मैंने. अब मैं स्किन ये कट चुकी हूँ, ये हमने सारा क्लोज़ कर दिया. अब सिर्फ एपिजोटमी की तरह से आपने उसको स्टिच कर देना है विजाइनल म्यूकोसा को, एंड दैट्स इट. मैं आपको कंप्लीट करके इसकी वापस शेप दिखाती हूँ. ये देन यू विल अप्रिशिएट के इसको इस रेड को कैसे क्लोज किया हमने. ये यहाँ से हमने कट लगाया था. यस, सो स्टैंड करें. या थैंक यू. ये एपेक्स ऑफ द एपिसोटमी है. हाथ खोल दें, छोड़ दें इसको, अनहोल्ड करें इसको थ्रेड को. अब हम इसको क्लोज करके पीछे तक लेके आ रहे हैं. ठीक है जी. ये फॉरसेप्स है मेरी. आपने इसको नॉन टूथ फॉरसेप्स यूज़ करना है. मैं टूथ यूज़ कर रही हूँ गोट पेल्विस की वजह से. Human vaginal skin is more vascular and more softer, so you need to use the soft instruments and very gentle handling so that it should not get injured. Tissues handling is very important. ठीक है. ये मैं इसको यूँ क्लोज करूँगी, ये यहाँ बंद हो जाएगा. राइट, ये इंट्राइटस बन जाएगा. ठीक है. ये इसके बाद स्किन है, ये इंट्राइटस बन जाएगा. अब हाँ जी, अब मैं एपिसोटमी की तरह कह रही हूँ. हाँ. अब ये हम आपको इंट्राइटस बना के दिखाएंगे. पकड़ो. इसको थोड़ा सा स्ट्रेच आउट करें, फैन आउट. यस, होल्ड, निकालें, छोड़ें, आप पकड़ें. होल्ड. ये आपको सही नज़र आ रहा है. ये मैं इंट्राइटस बना रही हूँ. मैं फाइनली आई रीच टू द इंट्राइटस. पकड़ती जाए. पकड़िए। छुइए। ठीक है, ठीक है, पकड़े। नहीं सही है। हाँ, ये आपका ये वाला पार्ट है। इसका एक थ्रेड ये होता है कि हम इसको अंदर से लेके बाहर निकालते हैं। ये देखिए, ठीक है, इसमें ये पकड़ें। ये मैं अब पेरिनियल बॉडी बनाऊंगी इसके बाद, ठीक है। ये सुपरफिशियल मसल्स हैं पेरिनियम के, उनको क्लोज कर रही हूँ। पकड़ लिया। Is that clear? छोड़िए, पकड़ो। हाँ। आप पकड़े। हम इसको कट करें अंदर वाली लेयर को। अब हम यहाँ से स्किन पे आएंगे और फिर इसको हम रिपेयर करके सबक्यूटिकुलर रिपेयर। पकड़े, ठीक है, इसको आप छोड़ देंगे। अब ये इसकी इस रिपेयर में ख़त्म हो जाएगा। ठीक हो गया। अब मैं इसको वापस लेके आ रही हूँ। ये एपिजॉटमी को जैसे हम सब क्यूटिकुलर्स रिपेयर करते हैं उसी तरीके से हम इसको भी रिपेयर कर सकते हैं। ये देखें, आपने ये लिया, ठीक है, ठीक है। ये आपने यहाँ से लिया, ये आप एपिजॉटमी की तरह इसको रिपेयर कर रहे हैं। सब क्यूटिकुलर स्टिच ले रहे हैं आप। अब आप आर्टरीज को निकाल सकते हैं। थ्रेड को फॉलो करें। हाँ जी, मैं अमूमन यहाँ पे इस तरह की नोट लेती हूँ जो कि आराम से बरी भी हो जाती है बाद में और प्रॉब्लम नहीं करती पेशेंट को। bury this knot as well. Scissor. Okay, now you can see the tear is completely repaired. Okay, complete. Any question? See, this is vaginal wall. I cut this part as well. ठीक है जी, ये विजाइना हमने completely रिपेयर कर दिया और ये रेक्टम, आप रेक्टम में फिंगर डाल के फील कर सकते हैं कि इसका एनल स्फिंक्टर कितना अच्छा बना है. ठीक है, एंड पेरिनियल बॉडी बन गई, आप देखिए, फील करें. ओके, थैंक यू.
डॉक्टर इसको यहाँ से लेना पर ऑपोजिट करके पीछे वो उसकी नॉर्मल
आपने यहाँ से लिया, इधर से अगर वहाँ से भी ले रही हैं तो आप यहाँ से लें.
नहीं नहीं अंदर आएगा नॉट
टुवर्ड्स दिस. आसान तो चलिए. बहुत दूर आती है, 1 सेंटीमीटर अपार्ट है, 1 सेंटीमीटर.
यहाँ तो पूरा लिया है. लेकिन आप ध्यान में ये रखें कि रेक्टम ये है टर्निंग 3 समझ आ गया.